All right, committee, welcome back. Those that are here and members of the audience and Department of Family Services, welcome back. I hope everybody had a great lunch. We will continue with the presentation. And if you want to go ahead and repeat what slide we're on to follow along. And reintroduce yourselves for those that are joining us online, please. Thank you.
Good afternoon. Thank you, Madam Chairman, members of the committee. My name is Roxanne O'Connor. I'm the Support Services Senior Administrator for Department of Family Services. Support Services, as you'll see on the slide, encompasses three major functions for the agency. Those functions are early care and education, substitute care licensing, and administrative functions. So when you think back to our core values that you heard about this morning, supporting the people that support the families is really our bread and butter within our division. Next slide, please. Much like the TANF grant that you learned about this morning, early care and education is funded primarily through the Child Care Development Block Grant. So we receive a block grant for about 70% of the funding that we receive for early care and education services. It's a $16 million block grant, and we as a state have a match of $5.6 million in both match and the maintenance of effort. Our maintenance of effort is about $1.5 million per year. If we don't meet that maintenance of effort, we will not receive the $16 million in block grant. So that's a very important funding. If we don't meet the match, then the feds will just not match us proportionately. So within the block grant and within our early care and education programs, we have different buckets that we are required to spend that money on, and that is a part of receiving the Child Care Development Block Grant. Those buckets are direct services or child care assistance, which I'll go into, also quality or professional development, and then infant and toddler professional development as well. For child care assistance, this is assistance that is received for income-eligible families to primarily go to work. Anywhere between 95 and 97% of our families who receive child care assistance are working families. Qualifying activities for child care can also include going to education, training, searching for a job in a time-limited way, or sleep time if you are a shift worker. So that goes to some of the mining industry that we have in our state. We can provide some services for that as well. We have 450 licensed and exempt providers across the state who accept child care assistance for these families. And it's really important to remember that these providers, these child care providers, really are the business that are supporting workers and businesses in communities. Without child care assistance, we know that many families, many parents wouldn't be able to go to work without that assistance that we are providing. So we see that as a core support for families. Again, like I mentioned, it is an income eligible program. So families who receive 150% of the federal poverty level, or about $4,600 a month, can qualify for this program. Again, we have providers across the state. We have 556 licensed providers across the state. That's about 21,000 slots in overall for childcare, and then about 61% of those providers accept childcare assistance. Child care assistance is where the vast majority of the block grant goes. So over 70% of the dollars that we receive and the state dollars that we put in go to the child care assistance program. Sorry, I thought that was a question. And then also in early care and education, we have childcare licensing and professional development. And so we have licensing staff that are across the state, all across the state, who go and they work with providers to make sure that they can be in compliance and stay in compliance with the regulations that we have for health and safety. So this includes background checks for staffing, training, ratios and group size, food safety, safe sleep, transportation, those types of health and safety components that we want to see in childcare programs. Our licensors go and work with providers to make sure that they can understand those rules and be in compliance with them. We also provide funding to the University of Wyoming to provide professional development services for childcare providers. So we know that there are unique needs for providers, and sometimes it can be hard to find training or in-person training. And so we've partnered with the University of Wyoming to put out some evidence-based programming for providers to be able to really help them improve the quality of their programs, know how to manage the children that they have in their care, know how to nurture them, know how to manage behaviors, and make sure that we're providing the supports to those providers and to those families. Also through University of Wyoming, we have programming that is specific to infant and toddlers, which again is a requirement of the block grant that we have that specific programming. And so there, the University of Wyoming provides credentialing for providers to be able to have that specific certification to care for infant and toddlers as well. Next slide, please.
Senator Hutchings.
I thought you guys were switching, I'm sorry. Roxanne, it seems like the federal government is providing food, housing, jobs, child support, early childhood development and education. It seems like some of this is redundant and that the Department of Health is also doing this early childhood education and care. How are we reconciling all this together where we're providing so much?
Sure.
Ms. O'Connor.
Madam Chairman, Senator Hutchings, thanks for the question. So the Department of Health, you heard this morning about developmental preschools, and those preschools are specific to families and children that need care above and beyond your standard child care program, right? So they have certain occupational needs, or they have certain speech needs, or any sort, the spectrum of developmental needs. That's what those preschools help with. And the preschools, or the child care centers that we work with, are anything from a home-based child care program to a child care center, and we work with the IDEA programs as well from a licensing perspective, but we don't license from a programming perspective. So that's the distinguishing difference.
Madam Chair.
Follow up,
Thank you
Senator
so much.
Hutchings.
I don't know. I'm just thinking, if I'm getting money for child support, it seems like I could go ahead and pay for my own early childhood education and stuff. So how is, again, it just seems redundant that we're just stacking money on top of money on top of money, where we were talking about this at lunch. Ben Franklin said, you don't want people to be comfortable in their poverty. And that's what we've done. You can just lean back and just have babies, and just the state just pours in money and little credit cards. It just seems like it's over the top.
Ms. O'Connor.
Question about redundancy.
Ms. O'Connor.
Madam Chairwoman, Senator Hutchings, so with many of our programs, and I'll speak just to child care assistance, we count child support as income. So when we're looking at our income, that's income that we would say, okay, that's part of your family household, so we're gonna say your income is higher, right? And so even if you do still qualify for child care assistance, it's gonna be less because you have that income.
Thank you.
Vice Chair Ottman.
Thank you, Madam Chairman. Just if you could give me a picture of what childcare looks like, because if they're going to the university, if they're getting degrees, if they're learning all this stuff, what do these is there licensure, all this regulation for the facilities, or what are we talking about to give? Because it doesn't seem like it could just be a neighborhood person, or could it be that babysits the children?
Ms. O'Connor.
Madam Chairwoman, Representative Ottman, early care and education can look different in different communities. It can be your in-home provider who doesn't have a college degree, and that's okay. Our requirements is that they have some early care and education training that we provide and we offer, and they have 12 to 16 credits per year that they have to get in that. They have to learn about safe sleep and those types of areas, but they don't have to have a degree. So it can be a small home childcare program. Those are called family childcare homes, up to a childcare center which has more kids. But all of the training and the education requirements are the same in those programs. So it's called a mixed delivery system, and that's what we want to see, is we want parents to be able to have the option to go to a home or go to a center based on what meets their needs.
Follow-up, Vice Chair Ottman.
Thank you, Madam Chairman. Is there, because I remember something about this and I'm not clear, is there by statute or by law a maximum that an in-home person can have now? It seems like we covered that. And like if I had children and everything like that, and I just wanted to take them up the street, can you do that and a person have 8 kids? Or what is the law?
Ms. O'Connor.
Sure, Madam Chairwoman, Representative Ottman. So in a family child care home, you can have up to 10 children. In a family child care center, which is still in a home, but you have 2 staff, you can have up to 15 children. More than that, you have to be in a child care center that is outside of your home. And there are exemptions, which is what we spoke about during the legislative session. And so there are exemptions where you can watch one family unit. So if one family has 6 kids, you can watch that whole family unit and not be licensed. Or you can watch 2 individual children from 2 separate families and not be licensed.
Please continue.
Okay, and in similar regards to licensing, we also license substitute care or congregate care programs. These are programs, again, that are in communities. These are youth residential programs. And so the Yes House in Gillette is an example of those programs. BOCES are an example of those programs. Sweetwater Group Home is another example of these programs. And so we have licensors, 2 licensors who travel across the state at least 3 times a year to go and help these programs be in compliance with health and safety rules. These rules are a little bit different because they are 24-hour facilities, and so we want to, and oftentimes youth that are here have higher needs, right? They have educational needs, they have treatment needs, therapeutic needs, and so based on the needs of the child and where they're placed, we ensure that those needs are getting met in those programs as well. Next slide, please. And then also within support services, I would be remiss to say that we don't have a number of administrative functions that we track each and every day. So we really are some of the backbone of the department. We're quiet, you don't see us a whole lot, but we do a lot to make sure that our staff and the providers that we serve are served well. So we have contracts and rules management that is done by one person. We have over 300 contracts for the services that you're hearing about today that this person manages and sees and makes sure that they're quality contracts. We have staff development and training. So we have 2 staff that help to make sure that our staff are supported in their needs to do their job and to serve families really well. We're undergoing a large shift in our staff development program to make sure that we really truly are meeting those needs, and so we're excited to see where that goes. We have the ombudsman, or this person is the person who hears about feedback from communities. These can be concerns. We also welcome positive feedback. And so this person receives about 900 phone calls or contacts per year to help individuals through our processes and to hear and get feedback and for us to look at that and find ways that we can always do better. We have communications and public records requests. So we receive public records requests just like any agency, and we do our best to respond to those. We have the Central Registry and Background Check Unit. The Central Registry is a program where we have employers, not just DFS providers, but employers from all across the state, schools, hospitals, nursing homes, who use volunteer programs, who use the Central Registry to ensure that anybody who has access to vulnerable adults or children isn't on our registry for abuse or neglect. So hasn't been found to be abused or neglectful of a vulnerable adult or a child. We run about 26,000 screens through the Central Registry per year, and we have about 1.5 staff that do that, and we have about a 1 to 2 business day turnaround time. So they do a great job of managing all the requests that come into them. And again, I think that that really does go to show how we are in communities and ensuring that there's safety beyond the programs that we operate just at DFS. Also, I am the information security officer for the department. I liaise with HR, and we have a legislative coordinator. So on those really late nights in the legislative session, if there's one person on YouTube, it's probably Rachel from our office, because she goes and she listens in very keenly to keep us all updated on everything that is happening and what you guys have going on. Also, like Danielle mentioned earlier this morning, we do have a financial services division ran by our CFO. They manage so many federal grants for us to make sure that the services that we're talking about today can happen, that we report out on them properly, that we draw down the funds properly, that we pass our audits, and that we are just making sure that we are being great tax stewards of these dollars.
Madam Chairwoman, members of the committee, again, my name is Christy Gordy, Senior Administrator of the Social Services Division with the Department of Family Services. Real quick, just on this title slide, it gives you some bullets about what we're going to talk about, but if we can just hop to the next slide to start. I think what you've heard a lot today, and you might be wondering, why is social services here to talk to us around child protection, juvenile justice, and adult protection? As Ms. Marks said earlier today, typically we're in front of our home committee of joint judiciary, but we do believe when we talk about the Department of Family Services that we talk about it holistically, and that when we talk about our framework of why home matters, that this is a very important part of the continuum, and it is the latter part of the continuum that is important to have a conversation about. And plus, I think they just don't want to leave me out. So real quickly, just when we talk about the continuum, you've heard a lot today already about the programs that are offered through the Department of Family Services, means-based programs or child support, but all programs really aimed at either helping families or individuals become employed or more self-sufficient so that they can move into a more stable and secure space within their life. That's important to the space of social services. It's actually quite critical. And when we think about it, what you'll see the slide, I'm not going to talk specifically about the slides, but more high level, you have those slides to take a peek at when you want. We really think about social services on a continuum, not really from a programmatic perspective. You might hear them be talked about within a child protection program, adult protection program, or juvenile justice program. That's correct, but really what we're looking at is these families on the continuum. And what the research tells us, and why it's so important from the work that we look at and from a prevention framework or a prevention lens, is all of the programs you just heard about this morning, including the programs you heard about from the Department of Health, make a big difference in families that are struggling. What we know nationally is over the last 30 years, when we talk about abuse and neglect, physical abuse and sexual abuse have declined 60+%. So states and nationally, we're doing a really great job keeping kids safe from physical abuse, sexual abuse. That doesn't mean it doesn't happen, it still happens. But what hasn't decreased very much is neglect. So that has decreased 13%. And what we're seeing when we look at maltreatment is that somewhere between 60–70% of those cases nationally, in Wyoming about 64%, those cases are within our social services division because that family is experiencing some type of poverty.
Now, poverty doesn't necessarily equal neglect, but what research tells us and shows us is that when a family or individual can receive those economic and concrete supports upstream, then it will and can prevent them from coming into crisis. So when we think about the social services division within the Department of Family Services, that's what we're talking about. We are first and foremost, we're looking at the priority of safety for children, youth, and adults. And you can skip to the next slide so that we can show the different populations that we're serving. But really our purpose is to really keep adults and families and children safe, first and foremost in their home and their communities if possible. Out-of-home placement may have to happen, and we will deal with that. We're going to talk about that in just a second. But as a department, and I think as a community, we are committed to upstream and preventive approaches in which we can strengthen families before crisis occurs. And no matter if we're dealing with, we'll talk about each of these areas, child protection, juvenile justice, or adult protection, what we're really looking at and what the priority is providing those meaningful opportunities for success. We want less involvement in the system by families, and we want to do that by providing those early supports. And we also want to collaborate and work across not just us, but our sister agencies, such as you heard from Department of Health. We've talked about the Department of Employment and Workforce Services, but also our communities. So the places you live and the community agencies and organizations that you have are really, really important to families being successful. And what we really believe is to build that stronger and really more responsive system that families, individuals, and youth and children need. So if you want to move to the next, can you pop back one slide, please? Thank you. So really here's just some basic information around the different doors that a family can come in. And when we're looking at this slide, we're really looking at a slide in which something has happened. So maybe prevention didn't work, maybe those supports and concrete supports aren't there. Maybe we're gonna work a prevention case with them. But we have 3 different doors when we're really looking at this. We have child protection. I will say, just as a note, if you have your slide out, one thing I would make a note to add, we missed a statute under Child Protection Act. So we missed 14.3201 through 214. So just so that you have that if you're interested, that's another set of statutes that relates to that work. And then we have our juvenile, and when we really talk about child protection, really we're talking about reviewing, acting on reports of abuse or neglect when it relates to children. When we talk about juvenile justice, we're really talking about youth, and we're really focused on rehabilitation in lieu of punishment and offering and providing those services that those youth may need. Is it mental health services? Could be education. It could be family supports as a whole. And then as we talk about, and within that, you'll see a carve out there for children in need of supervision. It's also in the space of juvenile justice, but really when we're talking about what we call CHINs, is we're not talking about delinquents there anymore, but we're really talking about more of your behavioral needs that we see. We see a lot of mental health, but this is where families are needing supports with regards to raising, or they're struggling with their juveniles. We have adult protective services as well. You'll see it's a very tiny, so good luck if you can read it, footnote. It's not on there because those are not filed through court actions by us typically. No, we do not as an agency. I want to just a few things for educational purposes. We, the Department of Family Services, first and foremost, cannot remove children from their home. Law enforcement and medical are the only professions in this state that can make a decision on removal. Now, that doesn't mean that we're not having conversations with medical or law enforcement if they're concerned about a child, but at the end of the day, the department cannot make that removal. That's the same when we talk about adult protective services. We actually do not take custody of adults. So there are a lot of different spaces in which we're dealing with vulnerable adults, whether it's neglect, exploitation, abuse, could be self-neglect. The only time we're likely in court is when we have to file a petition of emergency services, and that's just, it's become a space where that adult truly is in harm's way and needs some type of intervention in order to keep them safe. Typically in all of these, we prefer, as I mentioned, for them to stay in home and in their community with regards to the services that they need in order to get where they need to be. If you want to move to the next slide, I'm sorry. Which you might have already been looking at, but we're really looking at community-based services. As I mentioned before, Community is very critical to the work that we do. You've heard it mentioned a lot already this morning, but once we jump into this space, and these are just some examples, non-exhaustive, that's very important. There is a lot of work that is happening in the communities. You heard about some of the money, TANF and others that are going into the communities already this morning. There's other federal funding that flows through the Social Services Division that go into the communities to provide the services that families and children need. So these are just a few examples that you'll see up here in which we do some work. There's crisis centers in which you all, in some of your communities have those. That's really a space for children to go before they may have to come into out-of-home placement or parents need a break. Plans of safe care is a really, and then I'll probably move on just because of time, but plans of safe care is a really important one. It's pretty new to Wyoming. It's not just DFS. This is a system-wide, we partner with Department of Health, with hospitals and others in this space. And this is really around substance abuse and moms, and really coming into that space and saying, can they create a plan of safe care so that they can keep that child safe at home with them and then they don't have to come into the system. So a lot of really great work is happening there in which infants and babies are able to stay home safely with the community wrapped around them instead of them having to come into the custody and care of the Department of Family Services. Because we do all know, while it is important and necessary sometimes, a child coming into care of the Department of Family Services doesn't make it better for them. It's still a very hard road for them, even if they are removed from an unsafe situation. So next slide, please. So real quickly, as I mentioned, these are just, again, some more conversations around each of those areas that we talked about. And as I mentioned before, we're talking about child protection. I gave a little bit of overview. We're really looking at that abuse and neglect. We're really working and focusing on reunification. We are required to, but also it is in the best interest of families for us to first and foremost try to reunify those children with their parents. As you'll see here, we do, before they ever even come to out-of-home care, you'll see that very first bullet, which is those voluntary prevention services. So again, you're gonna see this on every slide going forward, that prevention services is there in the beginning. If they do have to come into out-of-home placement, however, and right now we have about 724 kids in out-of-home placement. About 456 of them are in family-like setting, as you'll see on this slide. That means foster care, family foster care. About half of those are with relatives or kin. And we know that's important because the research does tell us that when children are placed with relative or kin, if they have to be out of home, they do better in those settings. The remaining around 156 are in some type of congregate care, which Ms. O'Connor already just spoke to you about, maybe a group home, maybe a residential treatment facility. It might be a psychiatric treatment facility in which we then partner, obviously, with the Department of Health with regards to that level of care. We are, like I mentioned already, always looking for reunification and some type of permanency. Doesn't mean we always reunify. There are instances in which there has to be a different permanency plan. Another important component of this, and as we look through the next slide of juvenile justice, is that component in which they do reunify or go home. And it is very important for this to be able to transition them back into the community or back into their home, which I will say is another point in which all of the programs we just talked about this morning are very important as well. If they are going back into the family setting, does the family have everything that family needs in order to sustain those children coming home and keep them safe? We know that most of the time in our case plans, we require them to work. We require the parent to have a stable household. We require a lot of things that I will say without some of the programs that we've talked about, it would be very difficult for parents to achieve that and then receive their children back in their home and then be able to sustain it. Another, I think, thing that's important as we talk about reunification is we reunify about 72% of the children that are removed. And I think in Wyoming, there's a really great job being done, not just within DFS, but across the system, because we only see about 5% of them re-enter the system over a 12-month period. So most are going home and staying home, and that's what we want. Next slide, please. So juvenile justice, it's really a lot of the same things. I will say, though, we're talking about a different population here, and we really work in a space of delinquencies. We really do have a lot of, you'll see on here, community juvenile services boards, again, in some of your communities. in which they are really working for diversion. So we really first and foremost are trying to figure out where in our communities is there opportunity for diversion so that we don't have youth coming into the system who maybe could do better outside of jail or placements when you talk to Dale or Chris or hear from them with regards to a pretty secure facility. So what does the family need, not just the child, but what does the family need in these situations in order for that youth or that juvenile to stay home? This is another big component, and we now have a funding source in here when we hit this age of youth, and which is called independent living. So we really always would love them to transition back home, but if they have to transition into the community, what are those skills and education that that youth needs in order to be able to be successful on their own or back within their own community? And again, we're kind of starting our prevention cycle all over again. So that youth may need SNAP when they transition out because maybe they're not quite ready on their own. Those youths may need some other types of community services, but the hope is that they're not on them for a long term, but can get them to a space of safety and security so that they continue forward out of the system. Next. And so our last area that we talked about was adult protection.
We have one question.
Oh, sure.
Senator Scott.
Question is on the slide on the child protection services, the out-of-home foster parents. Are you having success getting an adequate supply of good foster parents, or is this a continuing problem?
Miss Gordy.
Madam Chairwoman, Senator Scott, we are in a good place. I think it is always a space in which we are constantly looking to recruit more people that are willing to engage in the activity of providing a foster home, which we know can be very difficult. We, however, have been quite successful. I think we would always say it would always be beneficial to have more. But overall, we have very good, strong men and women who are choosing to foster children who unfortunately have to be in out-of-home placement.
Okay, please proceed.
Okay, back to adult protection. Again, this is a little bit different of a space than the child protection and the juvenile justice. Again, they're pretty voluntary unless, as I explained, there had to be an emergency services petition filed. And typically, and there's a separate task force, mental health and vulnerable adults task force really is focusing a lot in this space. Again, sometimes I think it can be deceiving. Adult protection just doesn't mean elderly. Adult protection, we're starting at youth that are 18 and over. And some of our most vulnerable population are youth 18 to 21. One thing that I will mention that can be a whole other topic of conversation, and I think Director of Health would agree, is we have a very high needs population of youth. And when I say high needs, we have a lot of youth who have a lot of needs when it comes to behavioral and mental health. And that is a space in which we struggle to be transparent, just because within the state of Wyoming, it is hard sometimes to find and have all of the services available for the youth and what they need. We know we have, I think so far in 2025, we had 11 youth that we've had to place out of state. It's probably more now from when I pulled that number. And they have to be out of state because just unfortunately within the state of Wyoming, those services don't exist. Or they've been placed somewhere and something happens and they no longer can stay in that placement. So I say that because our population within adult and vulnerable adults does capture that 18 to 21-year-old. And that is actually the highest number of where we're needing potential guardianships is within that population and not so much within the elderly population. Now, guardianship is the most restrictive space within this. Sometimes guardianship is necessary. But for the most part, we're really looking as a community. Again, this is a very important space for all community members to wrap around these individuals when it comes to food security, housing, and just other components in which they can hopefully stay home or in their community or with a relative and not have to be either placed somewhere or put in or have a guardianship within that. Again, you'll see on there, we have adult protection teams. We also have child protection teams. There's not enough time to talk to you about that today, but we were always happy to. Next slide. So this just is an overview of the different types of cases we had for state fiscal year 24 to give you an idea of really where we're seeing our populations. You can hop to the next slide. So here's our budget. So as you heard in the beginning, we have about a $325 million budget for the agency. Our division is about $155 million of that. What you will see is a difference between the Social Services Division and from Ms. Liver's Division of the Economic Security, and even with Ms. O'Connor, is about 62% of the budget of social services is state general fund. The majority of that state general fund is spent on out-of-home care. So out-of-home care is important and is necessary. It's very expensive. So what we know is there are a lot of cases that do come in where kids have to go out of home where they probably could have stayed home. And if we can focus more upstream, our hope is that they can stay home and for a lot of reasons, not have to come into care, but from a very fiscal perspective, the majority of state general fund is spent here. You can skip to the next slide. And again, I'm not going to spend any time here because Director Johansson set the stage. And so if you guys have questions with regards to HR 1 and other things happening at the federal level, I'm more than happy, but there is information on there as it relates. There's no direct impact, but potential impact as it relates to PAYGO. I know that was a lot of information. I went probably quicker than I wanted to. However, I know you're short on time. There's a lot of people sitting behind me that are not here to listen to us, but I'm glad they're here to listen to us. We still have the 2 youth facilities that I know want to share a couple minutes of some information with you, but happy to answer any questions.
Representative Yen.
Madam Chairman, thank you. Ms. Gordy, thanks for being here. It's hard for me to remember your last name. Because it's different.
Yes. Fair.
So I appreciate you restating it at some point in the presentation. Something that's not in the slides that I'm always a squeaky wheel about, and I apologize for being the squeaky wheel about this, is Medicaid birth cost recovery. I'm curious, I know we spent $300,000+ in one of the last budgets to give the Attorney General some attorneys to see if we can squeeze more blood from a stone. Are we actually recovering more money than we're spending at this point, or are we still spending more money than we're recovering?
Madam Chairwoman.
Ms. Gordy.
Representative Yen, and briefly, maybe those may not understand what birthing costs are that Representative Yen is talking about. I believe we're looking at 9 years ago, some legislation was put back in place that used to be in place, it was removed and that came back, in which we're backtracking to child support. So we are stepping outside of social services very quickly back to the child support program, in which the child support program is currently by law required to collect birthing costs. So a mom that has on Medicaid and has used Medicaid for birthing, it is required for us to then go after the father for birthing costs. There was a lot of work done, there's some caps, and there's a lot of information that I'll leave on the table for you all if you're interested to go find. So to answer your question, Representative Yin, what we know as of today is, and this data is as of January, so we haven't updated it in a few months, but about $78 million in birthing cost expenditures were referred from, this is a partnership between the Department of Health and the Department of Family Services. So referred to the Department of Family Services, this is dating back to 2018. So that's been 7 years. We reduced to judgment. So again, child support's a very legal process. So out of that 78 million, we've reduced to judgment about $950,000. Of that, and a lot of this is based on FPL and different things on what the judgments can be. $708,000 have been recovered by the child support program, again, who are very good at the job that they do, but this is a difficult space. Here's to the question, what we need to know, of that $708,000 that's been recovered, 50% has to go back to Medicaid. So that leaves us at about $350,000 actually collected. We have expended around $500,000 to administer this program. So we're in the red, about $150,000, Representative Yin.
Excuse me, did any lady, one was found in the ladies' room?
If you would just hand it to LSO right here. Thank you.
That's mine. That's mine.
Yep, thank you. Okay.
Madam Chairman.
Oh, we have another question, Representative Yen.
Yeah, Madam Chairman, thank you. So the state has gotten back from these, I guess we'll call them deadbeat dads, $350,000, but we've spent, so since the bill got passed in 2018, the state has spent 500,000 to get back 354,000. That's correct?
That, Madam Chairwoman, Representative Yen, that's correct in that, and I don't want to speak for the Department of Health, the 500,000 is the administrative expenditures for the child support program.
So, Madam Chairman, Ms. Cordy.
Representative Yen.
Thank you, Madam Chairman. That doesn't include the amount of money that we also allocated to the Attorney General's office.
Ms. Cordy.
Madam Chairwoman, Representative Yen, I apologize, you did ask that question. No. And they did not, and we were unsuccessful in hiring attorneys to take on that role.
Thank you, Madam Chairman.
Representative Klauston.
Thank you, Madam Chair. Thank you, Ms. Gordy, for being here in your testimony. I was just looking on page 33, under 5916 tribes, state of Wyoming, $6.9 million, federal funds, zero. Can you tell me a little bit about why those funds are zero from the feds? Thank you.
Ms. Gordy.
Madam Chairwoman, Representative Klauston. Yes. It's because for the tribes, it's state general fund only. So the amount of dollars that flow through the legislature donor appropriation that are to the tribes through the Department of Family Services, again, for social services, is 100% state general fund. So the tribes may receive federal dollars outside of us, but this represents solely the dollars that flow through the Department of Family Services to both tribes through contracts.
Okay. Seeing no further questions, we'll move on to the Boys and Girls School staff.
Madam Chair, members of the committee, my name is Dale Weber, and I'm the superintendent at the Wyoming Boys School. We will be quick. Obviously, we each only have one slide, so I'll just give you a quick overview of what the Boys School is. You can obviously see the numbers. Our budget is almost all of it, over 90% is to our staffing because we're 24 hours a day, 7 days a week, 365 a year. We have people there taking care of the kids. So most of our funding is spent towards staffing, and then approximately 60% of the remaining funding is spent on food and utilities to take care of those kids 24/7. So most of our money goes toward the kids and their safety. So for those of you who aren't familiar with the Boys School, we've long been considered the highest level of corrections in the state for juvenile males. So by statute, we're really called more reformatory. And philosophically, we really look at ourselves as more of a reform school setting, because we know that developing relationships with the boys that come into us goes a lot farther than just restricting movement and ordering them around. So our average length of stay, or actually I should go back, our average age is 16 years of age, so just over 16. We can take kids anywhere between 12 and 21 years of age. But a bulk of our students are going to fall between 14 and 17 years of age, and a majority, the average, is 16. Our average length of stay is just over 6 months. That is obviously different depending on the age of the student, the level of criminality, the severity of the crimes or the delinquencies that they were adjudicated for. And then our sexual offender program is actually a 12-month program, so our length of stay is a bit longer for those students. So when I say that we're more reformatory, we've really put a major focus on, we understand that between 70 and 90% of youth that are locked in a facility like ours have a history of trauma. So we've put a great deal of focus and emphasis on trauma responsive care. We've had our entire staff trained on trauma responsive care. We've put a great deal of focus on de-escalation techniques, because anytime you have to put hands on a kid, there's a chance for injury. So we've put a great deal of focus on that. And then just trying to get them more opportunities that are off campus. So over the last 2 years, our students have engaged in over 200 activities that were off campus, whether that be community work projects, We work with the senior center. We go in and scoop walks during the snowstorms in the winter. Our students do, and then in the summer, they'll go and take care of yards of seniors that can't take care of their yards. We volunteer at the animal shelter. We work with the community garden. We do a lot of individual projects for the community, setting up for barbecues, different city events. So we try to get our boys off campus as much as possible and out in the community and interacting with the community in a positive way, which they're not used to in their own communities usually. They're not the kids people want around. So they're starting to learn that you can interact with the community in a positive way. So we've put a lot of focus in on that, and we're seeing massive decreases in our numbers of restraints and detentions. So we're seeing a lot of good positive impact with the emphasis that we're putting on. And honestly, we have a lot of people that really care about the kids that we work with. Some people have been there 30 plus years. So we have a lot of people that have dedicated their entire careers to what they're doing with these young men. So it's pretty neat to work with a bunch of people that care about the kids like that. So I'll stand for any questions.
Vice Chair Ottman.
Thank you, Madam Chairman. Just a point of information, when you were saying about you're getting them outside and getting them to be around people and things like that, a lot of times people are said to have a mental health problem when it could be anxiety or, let me see, just, I don't want to say confusion, but frustration or lack of knowledge about how proper actions are. Are you finding that through the way that you're handling these young people, that they're able to go home and do better with their families?
Mr. Weber.
Madam Chair, Representative Ottman. Yeah, I mean, we don't provide mental health services. We do have an agreement with the mental health agency in town, and they send therapists and case managers out to work with each kid. And they do engage in family therapy with the kids and their families. So yeah, I think that's a major focus on what we do, is working with them and their families on their behaviors, because everybody knows kids, you know, if they have a good relationship with their families, they're less likely to be delinquent. So that's a great point. And yes, we do find more improvement the better we can do with their families.
Okay, please continue.
Madam Chair, members of the committee, my name is Chris Jones, and I'm the superintendent of the Girls' School. I also have the good fortune of following Ms. Gordy and Mr. Weber. They pretty much set the stage, and I'm just here for the final curtain call. Girls' School is very similar to the boys' school. We serve the same ages. And, you know, as Ms. Gordy talked about and when Ms. Marks talked about initially, it really is about being safe at home. And so everything that we do at both facilities, but at the girls' school, we provide them with all kinds of opportunities, A, because it's what's best for kids, but B, we really want them to be successful when they discharge. We start discharge planning from the moment that they're committed to us. We are one spot in the continuum of care. And so back to your point, Representative Ottman, is, yeah, the whole point is whatever services we provide, education, high set, independent living skills, outdoor activities, mental health programming. I have one mental health therapist, but the vast majority of the mental health stuff that we're connecting them with is through their community mental health centers. So some of the stuff that you saw with Department of Health is we rely on that, and we do that telephonically or video. But it really is about setting the girls up to be successful. The girls' school's motto is a chance for change, and that's how we operate. We want this to be an interrupter of some of the things that have got them system involved. Hopefully, with the ultimate end is that they don't continue to be system involved. It saves the state money, it's the right thing, and it creates better communities in Wyoming. Our average age is right at 16. So like Mr. Weber said, by statute, we can take 12 to 21, but functionally it's 13 to 18-ish. And our average length of stay is right at 7 months. When the girls are committed to the girls' school, they're committed for an indeterminate period of time to complete our program. So it's not based on crime or what. It's said that in order for you to be discharged, and like I said, we start talking about that at the very beginning, is they need to make progress in the components of our program. What that does for us is that we don't get a kid that says, whatever, I'm just here for 6 months, I can do anything for 6 months. It says, no, in order for you to get discharged, which is a primary motivator for most kids, this is what we need to see from you. Participating in whatever is prescriptive for you educationally, behavior-wise, and then vocationally. So again, I had the good fortune of having two people in front of me that pretty much set the stage. I'll stand for any questions.
Senator Scott.
Oh, sorry.
Question for both the boys' school and the girls' school. What is your capacity at any one time?
Superintendents.
Madam Chair, Senator Scott, our capacity, we are staffed to hold 60 students right now. Physically, we could hold 75. We have 75 beds in the 3 buildings that are open, but currently we're staffed to safely hold 60.
Madam Chair, Senator Scott, the girls' school has 65 beds. We are staffed to for about 32. One of those beds is, one of those dorms of the 65 beds is a non-operational dorm. We closed a dorm a couple of years ago, and so we do have its bed count. It's really dependent also on vulnerability and victimization. So all of the bedrooms at the girls' school are double occupancy, and they do not close and lock. And so we have to be very intentional about who we put in which rooms and with together, and then pairing that with the staffing.
Representative Yan.
Madam Chairman, thank you. Maybe this is more of a question for Ms. Gordy on whether we keep stats on whether these kids stay out of the system after their stint in the boys and girls school, or even not just the juvenile system, but in the prison system as well in the future. Do we have any stats on kids and keeping track of them afterwards?
Ms. Gordy.
Madam Chairwoman, Representative Yen, and not just to the boys' school or girls' school, but any placement, if they were placed as they were in our custody, we have some information. I think that there is opportunity to gather more information as we want to potentially see where these youth end up. A conversation for another day. However, I think there are some spaces in which confidentiality laws and data sharing restrict our ability to truly follow a child afterwards. And I'm not sure if Mr. Weber or Ms. Jones have anything to add.
All right. Oh. Committee, any additional questions? Oh, Senator Hutchings.
Thank you, Madam Chair. This is for the boys and girls school representatives. Do you guys see common denominators as to why these kids are coming in at the age they are, a little after puberty, 16-ish? What's going on at home? Is it the education system? What are you finding?
Superintendents, is there a common denominator?
Madam Chair, Senator Hutchings, I could tell you there's certain delinquencies that they get charged with. So we have a lot of, not a lot of violent crimes, but a majority of our kids are either brought to the boys' school or sent to the boys' school because of assaults, thefts, vandalisms. There are a few drug offenses, but really not as many as you might think. But I don't know that there's, even though we do get their background history, I don't know that we've ever done a deep dive into all of the students that we've had over a number of years to find if there's any single thing. But I can tell you that the more active their families are with them and the more active they are in their communities, the less likely they are to come to the boys' school.
Madam Chair, Senator Hutchings, I would agree with Mr. Weber. I also think when you start seeing kids, when school gets a little tougher, sometimes their school success is more challenging. There's a very strong correlation between school success and delinquency. And so you see some of that. I always joke that when kids are not attending school, they're very rarely out doing volunteer work. And so there's more opportunities for them to get in trouble. I would say that the biggest common denominator across the board is their levels of support that they have either with their families or their communities or a combination.
Thank you.
Senator Scott.
Or abuse at home, is that a common thread?
Superintendents.
Madam Chair, Senator Scott, yes. The vast majority of my residents have endured some sort of physical, sexual, emotional trauma, and that we know that contributes to why kids get system involved. And that's why we're very, like Mr. Weber stated, I don't know if any of you've been to the girls' school. It doesn't feel correctional. It is very much intended to be their children, their Wyoming's children. And so everything that we do because we want them to have a better life, hopefully getting some, and this goes to the whole spectrum within the entire agency, is getting them services for the family so that when they're transitioning back, they're not transitioning back to the exact same environment that contributed to why they were placed with us.
Senator Steinmetz.
Thank you, Madam Chairman. I have a couple of questions. One for boys and girls school. Have you seen an uptick in the need for services with the Cowboy Challenge Academy going away? Because that seemed to be a really good program. So that's my first question.
Superintendent Jones or Weber?
Madam Chair, Senator Steinmetz, we have not actually seen an uptick since the Cowboy Challenge Academy closed. We would occasionally step kids down to that program, but generally if they come to us, they've committed something that's considered a crime in adult court, but it's delinquency, and it's not just educationally based. So no, we have not seen an uptick.
Madam Chair, Senator Steinmetz, I would echo what Mr. Weber said. We used it as a resource, often post program completion. I wouldn't say that we've seen an uptick.
Okay, thank you. And then
Follow up, Senator
thank
Steinmetz.
you, Madam Chairman. The next question is for Ms. Gordy, and I want to take you back to your stats on sexual violence toward children. And I struggle to find the statistics, but it seems like it's gone up, not down. 60% decrease is quite a lot. So has the reporting changed? Has the definition of what sexual abuse changed? How can you statistically justify that number?
Ms. Gordy.
Madam Chairwoman, Senator Steinmetz, more than happy to share the research that we have with you. It may be difficult to find. It is dating it's starting back to 1990. So it's looking at stats from 1990 to 2025. So we will own that. We know that we are looking for some updated research. There's maybe potential for a slight uptick. But what we do know, and I can't answer if the definition they use is different than others, but what we believe is that is pretty accurate when we look at not just our own caseload, but other caseloads across the nation. It is a drastic decrease. I would say that would be supported by the child protection system was created to deal with abuse, physical abuse. The child protection system in its creation and infancy was not contemplated or built to deal with neglect. So I think that's why you see a drastic difference. There's been a lot of focus, effort, services, funding put to addressing physical abuse. So we see that decrease, not the same in the other space of neglect.
Madam Chairman.
Follow-up, Senator Steinmetz?
Thank you, Madam Chairman. Well, I really hope those statistics are right. That would be a great gain for us. So I really hope so. So thank you. And I'd love to see your research.
Committee, any additional questions? Okay, seeing none. Superintendents, thank you for joining us. DFS, thank you for joining us. All right, we will open it up for public comment. If there's any members of the public that would like to come forward in regards to anything that's been presented by Department of Health or Department of Family Services. We've got a few chairs, so let's fill them up. Right, sir, if you'd please state your name and who you represent, and we'll hear your succinct comments.
Good afternoon. My name is Russ Schriftman. I'm representing myself. I'm a citizen living in Casper. I want to comment on two items from this morning. First one was on long-term care services under Medicaid. I have been a licensed insurance agent focusing on Medicaid, long-term care insurance since the 1980s. Long-term care, I'd like to call it personal care, so people understand it's not medical per se. It is care for somebody who, let's say, has Alzheimer's, like my mom had, where I cared for her with the help of a live-in companion named Nora. We cared for my mom for 2 years before she died. She had long-term care insurance. Over my career, my clients have received $3 million of long-term care services through their insurance. These insurance plans are not funded by the government in any way. The federal government passed a law called the Long-Term Care Partnership, which I worked on. It gave the states a way to partner with private long-term care insurance companies, and again, not funding the policies, but it creates a deductible for Medicaid in that, let's say somebody can only afford a 3-year policy, and let's say that policy pays out $400,000, and then the person decides they're going to apply for Medicaid. Medicaid may come in as a backstop. So there is a program in Wyoming, and my only thought is that most Wyomingites don't know about the program. It's a way to maybe reduce some of the costs of Medicaid because the costs keep going up. It's funded federally and state. So that's my first comment. Second comment had to do with the vital statistics that was mentioned this morning. One of those areas is abortions that are committed in Wyoming. When the last report came out, I asked a staff member, how is this verified? There is no verification. So it's really the honor system that a business that's committing abortions tells the state what the numbers are, both the numbers of abortions done, the gestation of the babies, the age of the mothers, and all of those items. So maybe we need a statute for that. And those are my comments this afternoon, and thank you for your service.
Thank you, Mr. Schiffman. Any questions from the committee for Mr. Schiffman? Okay, seeing none.
Oh,
Senator Scott.
Madam Chairman, when we were considering a statute in that particular area before, one of the problems we ran into was the medical profession uses abortion in a term in a different way than the rest of us do, and was calling many things that most of us considered just miscarriages, was calling them spontaneous abortions. And it was causing a lot of confusion in the statistics. And Chairman, do you think is that confusion persisting? Are you seeing any evidence one way or the other on that one?
Mr. Schiffman.
Madam Chairman, Senator Scott, there shouldn't be any confusion between a spontaneous abortion, which is a miscarriage, meaning the baby has already died, and a live baby that's being killed. And any doctor should know the difference between a live baby and a dead baby.
Further questions from the committee? Okay, seeing none, thank you, sir, for joining us. Please state your name and who you're with, and we'll hear your public comment.
Madam Chair, thank you. My name is Jeff Daugherty. I'm here today on behalf of FGA. I'm going to be very brief. You'll be delighted to learn, Madam Chair. But I wanted to first thank this committee for all of the work you put in and all of the travel you put in. I know I tell you guys this every time, but my gratitude persists, so I'm going to share it again. I also want to thank the staff. It was clear to me that they had put a considerable amount of effort into those presentations, and I found them very edifying. So I just want to thank the staff for all the effort they put in. Madam Chair, I'm here today to speak briefly about the SNAP issue that this body heard about today. It's an issue that I was involved in last year at the legislature. It's the Supplemental Nutrition Assistance Program, and I think that's a key word in the title, that we should not be using a nutrition program to advance the purchase of junk foods. And I appreciated the director talking to us about the percentage, and I think she's correct in that percentage of how much of the SNAP purchases are actually attributable to junk food. And I would tell you that right now, we've got a crisis in Wyoming and across the country. I didn't bring data for kiddos, but for adults, it's 31% of our adults are obese and just under 10% are diabetic. And so I really think we need to do something with this program. And Madam Chair, I think we've got some precedent. During the legislature, when the representative ran the bill, we were actually leading the nation in the area of SNAP reform. Right now, we've got about 5 states that have legislation pending. We've got about 2 states that have passed legislation but haven't passed the waivers yet. We've got 4 states that have both passed legislation and submitted the waiver, but the waivers haven't been approved yet. And then we have 2 states that, independent of legislative action, have submitted a waiver, one of which is our state to the south that rhymes with avocado. And it was actually surprising to me that they were one of the states that independently submitted. So it just showed me that this is a bipartisan issue. And then the last one are the states that have been approved, and there have been 3 states, Nebraska, Iowa, and Indiana, that have had waivers approved. So, Madam Chair, I'm going to bring my comments to a close there, but I appreciate the staff wanting to wait and further study it, but I'm really worried about the health impacts of waiting. And I would like to respectfully request that this body consider issuing a committee bill that could be considered at the next session. I recognize the challenges with the timeline, but I'd respectfully request that this body consider a committee bill for next year. Thank you, Madam Chair.
Committee, any questions of Mr. Daugherty? Representative Wasserberger.
Thank you, Madam Chair. Yeah, thank you, Jeff, for bringing your testimony here today. I was just wondering, do you know if there's any states where the Department of Family Services have sent a waiver request without any legislation force? They just did it voluntarily.
Mr. Daugherty.
Madam Chair, Representative Wasserberger, yes. So independent states were Colorado, and it looks like Louisiana sent it independent. Excuse me, let me check that. So waiver only, Indiana or Colorado and Louisiana, and then just those that have been approved. So there are 3 more. So those are 2 that submitted but haven't been approved yet. And then you've got Nebraska, Iowa, and Indiana that have submitted but have been approved. Sorry.
Thank you, Madam Chair.
Any additional questions? Mr. Daugherty, one of the other ways that a waiver can be requested is through the executive branch, specifically through the governor's office. To your knowledge, is there any movement for that request for Wyoming?
Thank you, Madam Chair. Madam Chair, I've had 2 conversations with a member of the governor's staff, and those I would characterize as productive. And during my last one, which was actually just last week, I was encouraged to meet with Corinne and some of the other members. So I'm going to take it upon myself to continue those conversations, even if this body decides to move forward with a waiver, because I think time is of the essence, and it would be much faster if the executive staff were just inclined to do that. And of course, my organization would be perfectly willing to offer support since we know what the approved waivers look like. But so I'll continue to persist in working with staff.
Thank you. Any additional questions? Representative Yen.
Madam Chairman, thank you. Mr. Doherty, I mean, we had plenty of conversation about this, but I think the one thing I didn't really think about was where does that bureaucratic burden lie? How much is it? I mean, that seems to be what the question that the DFS brought up of what they're watching other states are doing, because it hasn't been implemented yet in any state. So where do you think, does that bureaucratic burden lie on the private industry to update all of their systems so they have to filter out everything for SNAP? Or does that bureaucratic burden lie on the state where we're going to have to check every SNAP purchase to make sure that it does or does not have sugar in it?
Mr. Daugherty.
Madam Chair, Representative Yin, that's a great question. And to my knowledge, I think I have a good answer, but if I'm wrong, I want you to know that it was my intent to be right. So, but presently the way the SNAP works is you use an EBT card in order to scan a purchase, right? And so the cash registers today are already equipped to disallow certain items. So yes, there would be I think a small programming effort that individual businesses would need to do, but their cash registers are already set up and equipped to limit certain transactions. Does that answer your question?
Any additional questions, committee? Okay, seeing none, thank you, Mr. Daugherty.
Thank you.
Any further public comment on department agency presentations? Welcome. If you would please state your name and who you're representing, and we'll hear your testimony.
Thank you, Madam Chairwoman, and thank you to the committee. So my name's Pat Sweeney. I'm from Casper. Here today, Jen and I are representing Healthy Wyoming. And I'll let her introduce herself and then describe what Healthy Wyoming is trying to accomplish.
Good afternoon, Madam Chair. My name is Jen Lowe. I'm here today on behalf of Healthy Wyoming. Healthy Wyoming is a nonprofit that advocates for accessible and affordable health care for everybody in Wyoming. Historically, we have advocated for Medicaid expansion. Today, we are here to ask that we defend and protect current Medicaid. As a non-expansion state, we realize that we do not stand to lose quite as much as some of the other states that have expanded Medicaid. However, like we heard in the first presentation, 60 to 70% of our long-term care is supported by Medicaid. Additionally, we are concerned about the expiring of the premium tax credits that were part of the Inflation Reduction Act. These credits are set to expire at the end of the year. Currently, of the 46,000 folks that purchase insurance through the marketplace, 44,000 received this premium tax credit. When this tax credit goes away, that is going to make insurance more expensive for those 44,000 people to purchase. What we have seen and heard is between 10 and 11,000 people are expected to lose insurance when those premium tax credits expire. Currently, 10.5% of the state's population is uninsured, and that's unacceptable, and that is above the national rate of 8%. We are here to advocate for those people and to also remind the committee that the Wyoming State Constitution guarantees the right to access of health care. And I would argue that without affordable insurance, no one is able to access health care. And I think that is demonstrated by the high rate of medical debt that the state of Wyoming has. Our medical debt is higher than the national average. So again, Jen Lowe, Healthy Wyoming, and we would just advocate for affordable and accessible health insurance for all. Thank you.
Thank you, Ms. Lowe, and
So,
former Representative Sweeney.
thank you, Madam. The health department presentation this morning was terrific. And if you can't tell, for the new legislators, we've got professional staff members that are brilliant in my estimation and really need, I don't think we need to worry about fraud within our agencies. DFS, you just heard from them, but I'll use the booklet I'm concerned about the one big beautiful bill, and as it goes through the process and to the finish line, DFS in their presentation, I'll just highlight, slide 11, slide 12, references what could happen if the bill goes through in its current state. On slide 13 and 14, the food assistance federal changes, the elimination of local food purchase assistance. So we've already seen that here in Casper with Food Bank of Wyoming was buying from 14 different ranchers. That elimination through the Doge effort was the 535,000. I believe that's what that slide is talking about. And then on tab page 15 and 16 on food assistance on the SNAP program, those are startling numbers. If that goes through, what that could mean to Wyoming. Can we even possibly make up any of those differences? On one from the SNAP payment could go for the state from 3.2 million to 16 million if the federal government does what they're proposing. And so there's a number of examples in here, slides 19 and 20, and it goes on. There's many more. That should be startling to the committee, frankly, on what could happen with this. And back to the Department of Health, and so the CHIP program in particular, I'm very concerned about if the federal government does move forward with some of that, how we enroll 42,000 currently in the CHIP program, what will happen? And my belief is a lot of eligible people won't be able to become eligible with the new changes and updates. Low-income seniors, the 5,000 some people on that program. Again, you'll see it in DFS and other places, the amount of food that can be gotten through some of these programs for seniors, as well as there's a gap right there with seniors 55 to 65 before they become eligible for Medicare. It could be another danger point. The work requirements I'm fine with, but how do you qualify for a rancher, let's say, that's on the marketplace getting health insurance? How are they going to quantify that? Or if you're a caretaker, for somebody in the household, you're on the marketplace, but there's a work requirement. Are you going to have to take a job someplace, whether it's Walmart or a retail spot, to get the hours required, even though you can't, to leave as your caretaker or leave the ranch for those qualifiers? These are just some of the other things that I think we should be more aware of and care about, for some of the folks around us. And again, I think on long-term care, Ms. Schriffman's got a great idea, but it's not going to get us when you consider about 65, 68% of those in long-term care in this state, not in general, but in this state, need Medicaid to help pay to that, which I think also represents the Department of Health is going to have issues on qualifying some of our facilities. And with that, I just appreciate your work and just want us to be mindful of what's going on, as I'm sure you all are. Things aren't as rosy as they may seem with the big, beautiful bill and with HR 1. Thank you, Madam Chairman.
Committee, any questions of either presenter? Senator Scott?
On the business of the possible loss of the premium tax credit in the insurance purchase through the exchanges, I was not at all clear, would that take effect for this year or for next year? And what are the mechanics? Who's actually going to be affected and how much?
Mr. Sweetie, or?
Madam Chair, Senator Scott. So currently in Wyoming, approximately 46,000 people purchase insurance through the marketplace. Of those, 96% are receiving some benefit from this premium tax credit. So that number is about 44,000 and change. Those 44,000 people will be impacted by that loss of the tax credit, and that premium will go up beginning in 2026 when they go to purchase their insurance in the marketplace. And again, the expectation is that between 10 and 11,000 people will become uninsured because of the inability to pay that increase.
Madam Chairman, I would add to that as one example. I believe it's a couple, husband, wife, as an example, that currently is making about 82,000 combined income, purchased insurance in the marketplace. Their current premium is around $7,000. I think it's $6,982 for the year. That, without this tax being premium being extended, their premium will go to, I think it's an estimated $44,000 per year. And that's just one example. And a lot of our service workers, I never could afford to insure our employees. So a lot of our employees, service workers, a lot of employees, small contractors can't afford to provide insurance. So the marketplace is a needed thing. And the other problem with taking folks off the rolls that are tipped employees that's being proposed and probably implemented, that's another problem that's going to be created because they're not going to have the income to show and get a reduction on tax on another side, plus insurance.
Senator Hutchings.
Thank you, Madam Chair. Ms. Lowe, you mentioned something about a guarantee, and I don't know if it was a statutory guarantee, constitutional guarantee. Can you state where you find that?
Ms. Lowe.
Madam Chair and Senator Hutchings, Article 1, Section 38 of the Wyoming State Constitution guarantees the right to health care access.
Senator Hutchings,
Thank you,
follow up.
Madam Chair. When I look at Article 1, Section 38, I see not a guarantee, but each competent adult shall have the right to make his or her own decisions about their health care. So I was just wondering where that guarantee came from. But if it is in 138, I'll skim through it again and see if I can find out that where the guarantee is, and I thank you.
Committee, any additional questions of Mr. Sweeney or Ms. Lowe? Vice Chairman Ottman.
Thank you, Madam Chairman. Up until about 25 years ago, most, in my experience, my employers provided insurance. When the marketplaces, or whatever they're called, when they started coming into existence, things started getting a little hairy, and employers then did not have the need to supply them for their employees. And so we've progressed to this point. Also, with the technological advances and the wonderful things that are going on in medicine, when a shot costs $17,000, rabies, a series of rabies shot costs $37,000. To put that burden of responsibility on the citizens, which is probably out of 600,000, there's probably 35 or 40% of those people that are paying taxes. So to put that burden on them, how can we help people as a general population to be more responsive to what drugs and alcohol do to them? There's people that are on dialysis because they won't quit drinking. It's extremely expensive. Do I want them to pass on? Certainly not. But there's a place. When you're 250 pounds overweight, is there a responsibility that you should take before everybody provides for you? So I believe we've got a lot to look at in this conversation as far as certain things that are going on. So I appreciate your voice for people, but I think we have to look at it pretty realistically, is that this is a dilemma. And it can't be something that's just fixed by everybody else paying for it, because it'll just get worse. So that's more of a comment than a question. Do you see my point?
Ms. Lowe.
Madam Chair and Representative Ottman, thank you for the question. I do see your point, but I also believe in individual responsibility and individual choice. I do think that everybody should have the right to health care. I think that without health care insurance, you're not able to access the care that you need, likely not able to go to a provider who can help you make better choices with your diet. You're not able to enter a substance abuse treatment without insurance. So I do think that in order to access health care in this day and age, one must have health care insurance. So, but I do see what you're saying, and I agree. Thank you.
Okay. Thank you, Mr. Sweeney and Ms. Lowe, for joining us. Any further public comment? Okay. Seeing, oh. All right, if there's anybody else, if you'd please come forward. We're very far behind our schedule. Good afternoon. Please
Madam
state your
Chairman.
name and who you're with, and we'll hear your comments.
Thank you, Madam Chairman. Joey Carenti, Rural Wyoming Matters. Lots of topics that have already come up, lots of topics that are going to come up. I don't have an opinion I'm going to share with you on any of them. I'm going to ask for more of a consideration or a posture of the committee that Wyoming's always looking for efficiencies. We're obviously talking about issues because things are going to change, and with what's happening in DC this week, we may not have a choice. And some of the things that we have to deal with have to find different ways of addressing. I'm asking that when the committee consider their legislative proposals, that rural Wyoming not be left out of the picture. Not so much that we don't have the right to apply or utilize the same services, but ease of access, and mostly in the administrative portion of signing up, finding out if individuals or families are qualified for these. That infrastructure tends to go to the county seat. And here in Wyoming, 99 municipalities, 45 of them have a population of less than 500. 174,000 don't even live in a municipality. We are all entitled to, whether these programs should or shouldn't exist, entitled to the same opportunity to see if we qualify and utilize these. So if anything does need to change, any of the discussions come up saying, hey, we need to reduce this, change this, improve this, the effect on access, usability, and assistance for the rural community is taken as a consideration. Hope that was brief enough, Madam Chair. And with that, I'll stand for any questions.
Thank you. Committee, any questions of Mr. Corriente? Seeing none, thank you for joining us. Ma'am, please state your name and who you're with, and we'll hear your testimony.
Thank you, Madam Chairman. My name's Ann Clement. I'm the Executive Director at Wyoming 211. If you're not familiar with 211, I welcome you to visit our website at wyoming211.org. But we are the nonprofit that serves the state of Wyoming for information and referral. We were established in 2011 with about 87 resources in our database and covered about 13 counties. At this point, we cover the entire state with nearly 3,200 resources and services that all of our residents can access simply by dialing 211. We also are an excellent example of a partnership with a state agency. We work hand in hand with DFS through our Kinship Connections program. It's one of our 3 case management programs that provides support for families raising kiddos that are not biologically their own. So we talk about those dollars and how we're keeping kids out of the foster care system and keeping them with families. Our program does exactly that. We also manage the only aging, disability, and resource center in the state. Our navigator's based here in Casper. I just hired another one specific to Fremont County. So we are working with anyone over the age of 18 who does not qualify for a DD waiver, as well as anyone over the age of 60 who's finding challenges as they're aging related to cognition or their abilities to just move. And that actually is free of service. Both of those services are free of charge to anyone. They are not income eligible services. Our third initiative is our CommuniCare. It's our community information exchange. It provides an electronic platform to connect community-based organizations with medical providers and behavioral health providers so that they can process referrals to each other without having to burden the person themselves. So I know it's a lot of information. Again, all of our programs and partners are listed at wyoming211.org, but I just wanted to take a moment to highlight the fact that our state agencies are working with our local nonprofits to ensure that the residents of Wyoming are being connected to the services as best we can. And with that, I'll stand for any questions.
Thank you. Committee, any questions? Okay, seeing none. Thank you, Ms. Clement, for joining us. Okay. Is there anybody on Zoom for this? Okay, I didn't see any. All right, we are going to go ahead and close public comment on agencies, overviews, and updates. We're going to move on. I'm going to turn the microphone over to the good co-chair, and we will proceed.
All right, thank you, Madam Chairman. Thank you to our agencies for your assistance and input today, overviewing the work you do. So we're an hour and 37 minutes behind what we had anticipated. And so let's go ahead. The folks are going to present first. Governor's office, whoever's coming up, come on up. And we're going into maternal health and emergency services. First, we're going to review some governor's task force. We have some comments from both Department of Health and Blue Cross Blue Shield. So if whoever's coming up to present on these, let's do that. And then we'll go into a public comment period after that. So just by a show of hands, public comment, how many people are interested in giving a public comment on maternal health or EMS? So let's do EMS first. So I've got half a dozen on EMS, okay, and let's do maternal health. Half a dozen, 8 there, okay, perfect, thank you. All right, go ahead, Mr. Biggs with the governor's office. If you would start us off, let us know where you are in your, I guess we'll have a slide presentation up top, and then go ahead and proceed, please. And I know that the committee might have questions. Let's try to keep them as succinct as possible, and we can hopefully, I'm not saying we're going to make up a bunch of time, but hopefully can keep moving along. We are not going to take a break this afternoon, so if anybody in the audience or in the committee needs to take up and leave and do anything and come back, that's fine. If we run out of a quorum, we're going to stop. But if anybody needs to get up and go, there is no break this afternoon. You're on your own. Please proceed, Mr. Biggs. Thank you for being here. Introduce yourself and proceed.
Curtis Biggs with the Office of Governor Gordon, Senior Policy Advisor. Thank you, Mr. Chairman.
Please
Appreciate it
proceed.
very much. Today, alongside my colleague here, Franz Fuchs, Deputy Director of Department of Health, will be presenting healthcare task force items prioritized per discussion with co-chair Representative Rodriguez-Williams, narrowed down to a handful of them to bring before this committee today. I want to thank you for that time. Several of the task force entities and the members of the Governor's Healthcare Task Force are here as well. You may hear from them during public comment, understanding we are limited on time. The prioritized concepts include consolidated billing, which you'll hear from Deputy Director Fuchs. Department of Health was a part of that healthcare task force and has taken the lead on looking into the feasibility of that particular consolidated billing effort. Alongside that are basic and advanced life support obstetrics, family medicine, community of practice, tort reform, and graduate medical education. Those are the priorities narrowed down from over a dozen concepts that the task force put together over the course of 4.5, 5 years. I note that particularly because of the hard work they put in on that prior to my arrival to this position. That does seem like a lot of a list that's significant considering we've narrowed it down, but there isn't a one solution here. It's going to be a multitude of efforts within both EMS and health and maternal health. There is a fairly significant balance there between the two. When we talk about consolidated billing, that addresses the EMS aspect, which you'll hear about here in a moment. And then the basic life support obstetrics is also EMS, and the latter list there being for maternal care. So with that, I turn it over to Deputy Director Fuchs to move on to the next segment.
Please proceed, Franz. Welcome.
Thank you, Mr. Chairman, members of the committee. My name is Franz Fuchs, Deputy Director of Department of Health. We do have a slide presentation for you. The goal of that presentation is really to just provide a little bit of an update on the data, frame some of the problems between maternal health care and EMS, and sort of point to some of the common problems that we see between those two topic areas. So I know they're kind of separate on the agenda, but we do want to kind of point out that there's a sort of a common framing that underlies both of those. So beginning with maternity care, last year we presented a longer version of this deck, which began with the Marsha Dimes definition of what a maternity desert is. So we took the updated definition from Marsha Dimes from 2024, and this is on slide 4. And I think the main issue that we have with this is that there's a lot of counties, the counties in red in particular, are areas that have never had maternity services. And so we've tried to sort of update and refine that definition a little bit. So you see the next slide, slide 5, we divide maternity deserts into 4 main categories. One is the sort of long-standing maternity desert. These are areas of the state that have never really had this capacity to begin with. And those include, the far northeast corner, places like Sublette and Bighorn County, which are in the dark brown. There are obviously the not maternity deserts, which are the white. It's a little confusing here where it says the no desert, but that indicates there's not an issue there. The new maternity deserts, these are what we believe is the most pressing concern. These are areas of the state that previously had maternity services, but no longer do because of a closure of a hospital labor delivery unit. So we're classifying them as new. And then going forward, there are also some warning signs, particularly in the Lander County. And I should stop for a second. These are all county subdivisions on this map. What you see, these are basically major groupings of counties. So that's why there's more than 23 on the map. But you can see the Lander sub-county subdivision of Fremont County has the county's last remaining hospital that does labor and delivery. But we are seeing a concerning trend of a decline in those births in that particular hospital, with a lot of births shifting to Thermopolis. So we have that as a tan. Campbell County we have as a warning. That situation is fairly stable, but last year there were some indications that some of the market was shifting away out of state to spearfish. Other parts of the Northeast were sort of heading in that direction. So the number of providers in Campbell County is also relatively low per capita. So that's the reason why it's tan, but the situation is not degraded unlike Lander. So again, slide 6 kind of describes what I just went through. And then slide 7 shows the, again, kind of an eye chart showing these charts is the hospital. And you can see the trend over time in births since 2016. The red line is the trend. The little gray dots are the actual monthly count of births. And you can see, the hospitals that have ceased labor and delivery, like Carbon County, Lincoln County, Riverton. You can see when they stopped delivering. There's a general broad trend, decreasing trend as fertility rates decrease in the state. But I think if you look at, for example, Lander, that particular graph there, there's more of a sharper decline in the more recent years, and that's kind of concern. So that's why we have it as sort of warning status. Interestingly, you'll see that volume on Hot Springs, it's actually going up. It's bucking the statewide trend. We're actually seeing more births in Thermopolis over time, and I think a lot of that volume is being shifted north. Last year, we indicated, the primary problem that we are diagnosing this with is really hospital viability. The hospitals are really the anchor in these communities for labor and delivery. They sort of the workshop for the OB/GYN to deliver babies. The infrastructure, the staffing, the support is all very critical to successful care. And so that when a community loses its hospital, that really is the linchpin that holds it all together, and it's really hard to put it back. We believe that labor and delivery closures are really a symptom. They're not obviously deliberate. It's really a symptom of a broader financial stress on the hospitals, whether it's due to low volume generally or management issues. Generally speaking, there's going to be financial problems, and that leads to load shedding. And so they'll take their least profitable cost centers and start taking those offline. And labor and delivery is not a particularly profitable cost center for hospitals. There are underlying reasons for this. So slide 9, we have higher costs generally in the nurse labor market. As you all were made aware this morning, we have significant problems with that in our own department, trying to recruit and retain nurse staffing. Provider recruitment is also a challenge. The volume is also another factor here, right? So there are just a general trend across the state of fewer women giving birth. Other issues include comparatively low Medicaid payment rates. So as you saw this morning, around 30% of births are paid for by Medicaid. And you can see the relative cost, the reimbursement rates there, right? Medicaid pays around $7,500 for a birth, whereas private insurance will pay $20,000 plus. And that's your garden variety, regular birth without complications.
Senator Steinmetz has a question.
Thank you, Mr. Chairman. I was just wondering if you've correlated this trend with people needing specialized care. So as the healthcare industry has evolved and we have seen more specialized doctors, and speaking as a grandma who had a grandson in the NICU for, almost 2 months, that kind of care being needed more often than we have seen in the past, and it being available, if that some of it is that people are going to where they can get the services they need, and it involves the labor and delivery, and so they're actually getting the care, but it just is more specialized.
Mr. Fuchs, thank you.
Mr. Chairman, Senator Steinmetz, to my knowledge, I think the number of births requiring that specialized level of care and complications has not necessarily increased. I do think also there is a trend towards lower level providers sort of becoming more generalist. For example, family medicine docs are taking on a lot of births. We also have certified nurse midwives. There's an increasing a group of lay folks like community health workers and doulas that also assist. So I think it's kind of, I think the people definitely go out of state for that higher level of care. We don't have a level 3 NICU in this state. We only have Casper and Cheyenne have level 2, and then people will go to Salt Lake or Denver if they have complications. But I'm not sure that the number of people with complications requiring that level of care has increased over time. We haven't seen any data to that effect. We can certainly look at it, but I'm not aware of any trend in that direction.
Thank you. Senator Scott.
Mr. Chairman, for a while after the tort reform efforts failed, we raised the Medicaid payments for childbirth up to the limit to which the feds would allow for, including their cost sharing. Are we still there, or have we gone away from that? Do we have room to go back to get higher and still get that federal reimbursement?
Mr. Fuchs.
Mr. Chairman, Senator Scott, we certainly have room to increase those rates, and we have a couple slides here on that going forward.
Please proceed.
So actually, it's the next slide. So slide 10. One of the options that we are looking at, all these options here are sort of in our current role as the Department of Health, right? These are things we already do or could do without additional statutory changes. But one is looking at increasing Medicaid rates because we are a significant player in the market. Increasing the revenue for hospitals for labor and delivery would help. It's not a silver bullet. It most likely would stem the degradation of the overall system versus, cause hospitals to change their mind and restart labor and delivery. But one option that we actually looked at that might actually magnify that effect is taking our Medicaid providers that are critical access hospitals and subdividing them to two classes, those that offer labor and delivery and those that don't. And then for those that offer labor and delivery, if we offered a cost-based reimbursement rate for all of their services, not just obstetric or labor and delivery, but if you did cost-based for everything, that would provide a significant incentive for them to become part of that class and therefore offer labor delivery. So that would require more funding, no doubt, but it'd be a way to kind of leverage all the hospital services that we pay for, not just the specific labor and delivery components. We could also look at the maternity payment rates to delivering providers, so the OBGYNs themselves. Currently, we pay on a bundle. That bundle, again, is not a lot. We certainly could raise that rate, but then, of course, requires an appropriation. The next two, I just wanted to defer to Mr. Biggs to talk a little bit about graduate medical education.
Please proceed, Mr. Biggs.
Thank you, Mr. Chair. The two big pieces with graduate medical education, for one, we have GME here in our state. We have had it for a long time. We have two specific facilities that provide the graduate medical education in Casper and Cheyenne. That has not changed for what I'm hearing is 50 years. That's not to say that that is a bad thing, but objectively that is where we have the two sites. The expansion of that could include other facilities around the state. Even if it's a one-off, it may be difficult sometimes to find a student to get there, but this would go beyond WWAMI. It's just our students from the University of Wyoming. Expanding graduate medical education, the GME in our state, to essentially recruit, whether it's developing a council where we work with other graduate or medical education opportunities in the country for those institutions to send their students here for their practicum or their, residency. Thank you. Yep. This in turn would not only get us those residents here in our state to be able to understand whether it's rural health, if we were to customize and build customized residencies, such as we've talked about psychiatry residencies, rural residencies. This can be appealing to students from students all over the country. For one, to get them here to try it out and experience those which we have in full here in our state. But on top of that, the idea of it being a recruiting tool where they see they really do want to, they are attracted to rural medicine here in Wyoming. They are attracted to the lifestyle here in the state. They are attracted to being one of several or maybe the sole physician in some places in the state. And in turn, utilizing that as a recruiting tool for physicians in our state. So that is one of the elements the University of Wyoming, I have spoken with them more recently. It is early days in the concept, but they have started to look at that in terms of what the capacity, what it would take to implement that, particularly when it comes to administration at the university. So that's the GME piece.
Please proceed, Mr. Fuchs.
Thanks, Mr. Chairman. So the next slide kind of talks about these are options that have been talked about. We tried to sort of collect all of them. These are certainly outside the ambit of the Department of Health. These would certainly require legislation or even potentially constitutional changes in the case of tort reform, is my understanding. But we wanted to just put these up here as options that have already been discussed just for your reference. We don't have an opinion on any of these. One, for example, is looking at management assistance to distressed hospitals. So if it's really a management issue with the hospital and not necessarily a revenue or volume problem, perhaps the state could step in and help with that. I know there was a bill considered last general session that would look at trying to impose a little bit of local control over private hospitals' decisions to discontinue maternity services. There is, of course, malpractice tort reform, which is one bullet on this slide, but is a massive, massive issue that has consumed a lot of time in the past. And then some other states have sort of developed hybrid approaches to that, like risk pooling, where, if you participate in this quality improvement program, you can potentially get a discount on your premium, malpractice premium, or maybe the state would absorb some risk there. So again, no opinion on any of these. We're just sort of listing these as sort of ideas that have been floated in the past by various entities for consideration. And Mr. Chairman, per your...
We got a question, Representative Clouston.
Thank you, Mr. Chairman. Thank you, Mr. Fuchs. I'm fortunate to sit on a national healthcare committee, and I brought up this problem. We each got to present a problem. My problem was maternity health care in Wyoming, and it's not uncommon, right? There's 21 states that have task force right now working on this. North Carolina brought up, they pay $6,000 a year malpractice insurance for a physician when they're treating these rural communities that don't have other help. North Dakota and South Dakota have had really good luck with mobile units. They're sending out a mobile unit, nurses, physicians to underserviced areas, do prenatal, postnatal care, ultrasounds, that kind of thing. One of the things the committee brought up to me was the Federal Tort Claims Act of 1946 said Wyoming has 30 facilities that qualify. And this way, any of the tort reform claims would be paid by the federal government, would be represented by the Attorney General. We only have 3 facilities in Wyoming that are utilizing it. So I guess my question to you is if you can maybe work with the Hospital Association and look at that Federal Torts Claims Act a little bit closely, that might be another way for Wyoming to work on this tort reform. Thank you.
Thank you. Further? Representative Yin.
Mr. Chairman, thank you. Mr. Biggs. Mr. Fuchs, thank you for being here. I'm curious on why, when talking about provider recruitment, we haven't mentioned the policies that the state has passed recently where we threaten to put providers in jail for 20 years. Is that a conversation that you've had with providers where that risk has prevented recruitment?
If you care to presume anything about that. Sometimes you're going to be asked to give opinions on things, and you can pass. That is fine as well.
Mr. Chairman, we have not had those conversations.
Thank you. Further. All right, please continue.
So, Mr. Chairman, I know EMS is kind of a separate topic, but we can run through these slides and talk about the highlights of our study, if that's okay with you, and then
please proceed.
Talk about the common thread. So these are all findings starting on page 13, just the high-level summary of that EMS primer that we sent you all earlier this month. Very long report, hopefully useful, has some interesting data in there for your local communities. That's the main intent of that report. Some of the top level findings here, just in terms of volume and risk, there's 44 EMS agencies that respond. There's about 78,000, almost 78,000 calls in the state per year. 51,000 of those are reimbursable, meaning that those providers can actually get paid for that service. The other 34% are not reimbursable, meaning most insurance companies will not pay for that call because it usually involves something called a lift assist, where you show up to someone's house and maybe help them because they fell down. If you don't transport them to the hospital, you can't get paid as an ambulance provider. So about 34%, which is a very significant volume here, there's no way you can even submit a bill to a payer. We are also I was actually surprised to find out that the vast majority of EMS calls are local, right? So there's sort of this, when we were talking about EMS before, a lot of the narrative is about if you're on the highway and have an accident and fall into the borrow ditch, who's going to get you? That's sort of the narrative around EMS, but that's only really 1% to 2% of your total volume of EMS. Really, it is mostly local calls, mostly to an aging population. That really is the bread and butter of what EMS is about. Not to say that highway support isn't critical, absolutely critical, but I was just kind of surprised to see this volume percent was a relatively small part of the whole. So that's still 1,200 calls a year on highways.
Please proceed. Representative Ottman.
Thank you, Mr. Chairman. On that note, because is that policy with EMS? Because I know in my county, that is one of the major problems. There's a call, these people go and they, maybe they fell down and they can't get up, or maybe they're stuck or whatever it might be. It might be they have lack of oxygen and they give it to them, or something that the EMS personnel can fix right then and there, so they don't transport in the thoughts that this is the way to go. It's not necessary to get all that. Is there a way that we can adjust that for those instances? Thank you.
Mr. Fuchs, I think that's represented in the 34 that are not reimbursable.
So, Mr. Chairman, Representative Ottman, I think the main elephant in the room here is Medicare, right? The people that that are going to fall or need the oxygen are generally going to be older, generally going to be insured by Medicare. Medicaid does pay for what we call non-transports or treat and release. We pay for community paramedicine, which is where somebody might have a scheduled appointment with an EMT to check on them. But the problem is that volume is very, very low. Medicaid in general is not a big player in this market. We pay maybe 10, 15% depending on the county. So Medicare is going to be 40 to 50% of your volume. And so if Medicare changes policies to allow for this sort of, show up to someone's house, help them up, and then be able to submit that bill to Medicare, that would certainly add a lot of revenue and help somewhat with the bottom line. But that's a federal policy decision. We have no control over Medicare policy.
Thank you. Please proceed.
So next slide talks about response times. Shoot time, which is basically the time it takes from when the call gets received at dispatch to the time the ambulance starts going, is really the biggest variable in any kind of response time. And we sort of tried to categorize Wyoming's population by various, the response time areas. We broke it into 3 categories: those areas with a 9-minute or less response time, those areas that it can expect between 9 to 30 minutes, and those outside 30 minutes. And so we have some tables in the reports that show which counties and which subdivisions have some of the largest number of people living outside in that 30-plus response time. But there's the statewide numbers there. So 60%, roughly speaking, within 9 minutes. And those are going to be most of your people in Cheyenne and Casper, the bigger cities. And then 36% in the 9 to 30 zone, and then 6% outside 30 minutes. I think the key here to point out, though, is that shoot time really depends on whether an ambulance service is a full-time professional outfit or a smaller volunteer service. Volunteers are generally expected to be on call, so they have 10 minutes to get to their ambulance. So you can see how that might add a significant amount of time to that shoot time, right? And so we see the shoot times are much longer in, like plus 10 minutes in these small areas that are served by volunteers. Now, the volunteers obviously do it for a lot less, but in a way, there's a trade-off there. In the report, we do have some volume and service area maps. So here on slide 15, we show this is just a corner of the basin. Just kind of, we divided the state into kilometer grid squares and binned the number of calls happening each one on average in a year. This just shows that, generally speaking, EMS, it's very local. It happens where the people are. You're going to see it more EMS calls in bigger cities and bigger population areas. The next slide shows service area maps. So taking the same corner of the basin. When you look at these maps, you'll see sort of dark areas. That's the under 9 minutes. The little square medium areas are 9 to 30 minutes, and then the light areas are over 30 minutes. And then we color code it by the service that's most likely to respond. So this way, we try to show you in your local neck of the woods what ambulance service is most likely to show up and how long it's going to take them to get there on average. Getting to the cost issue, the cost really boils down to volume, right? There's this huge mismatch between the cost readiness and the number of calls you can really bill for. So we take 2 services as an example. Both of these are in Laramie County. Alban Rescue is a very small volunteer outfit that serves the far northeast corner of Laramie County. Their call volume is shown. This is just a random 2 weeks in January. And you can see the red line shows when an ambulance is out on a call. So there were only 2 calls that entire month. That service had 18 calls in a year. Yet they still have to maintain that readiness, right? They still have to have an ambulance ready to go. Now, they are volunteers, so they're not like sitting in the ambulance at all times. They have jobs, other jobs to do. But that ambulance comes, that readiness is what's really what your cost comes from. Whereas your revenue is coming from those calls. So if Alban Rescue, as an example, requires $400,000 plus or minus as a reasonable cost to operate that ambulance for the year, they may only be able to bill 10 of those calls, if 35% are unreimbursed. And so maybe they can get $5,000 of revenue to cover that. So there's basically a very large gap between the cost of readiness and the revenue that can be received from services. And it gets worse and worse as the service gets smaller. By contrast, the biggest service in the state, American Medical Response in Cheyenne, you can see their call volume in red. Their number of ambulances that are required to serve sort of an expected cost of readiness at the 99th percentile is shown in black, and that increases during the day as calls stack up and then goes back down overnight. Your least busy time is going to be early morning. And there, they need 4 to 7 ambulances to cover that volume, but they can bill a lot more to cover that. So the subsidy they need, AMR needs to operate they don't need a subsidy. They can make it all through billing. They can survive. And next slide kind of show that what we call utilization. So basically looking at that ratio of the number of ambulances that are out on a call and essentially earning money versus the ones that are required. The national average is between 30 to 50%. So most ambulance services naturally want to keep enough ambulances ready to go to be able to have 30 to 50% of them going at any given time. Because you still want some excess capacity to be able to take, when there's a lot of calls coming in at once. Only 3 services in the state are really above 30%. So there's really only 3 services that really could be expected to, if everything was based on revenue, only 3 services could really make it. Everything else requires a significant subsidy. And whether those subsidies come from volunteer hours, whether they come from tax dollars, whether they come from critical access hospital like Medicare enhanced revenue, there's something that these services are using to cobble together to fill that gap. And you can see the remainder, it falls off pretty quickly after that 30%. There's some, services on the border like in Fremont County, Frontier Ambulance. But really just the top 4 or 5 are the ones that are really kind of capable of making it without direct subsidies of some kind. So really, what is the problem here? It's this mismatch between fixed costs and variable service volume. We estimate that there's around 30 million of subsidies that essentially have to fill that gap between $67 million of cost, reasonable cost. These are the costs that are required to have an ambulance to answer those calls, and a potential of $37 million of revenue. And I kind of mentioned the various types of subsidies there. But our point in this report is that some of these subsidies are really more sustainable than others. The system has developed since the 70s with a strong reliance on volunteers. Volunteerism generally is declining in the United States. More and more services are having to fill those positions with paid staff because people aren't volunteering to the extent they used to. So if you consider volunteer labor as a subsidy, that subsidy source is not going to be as sustainable in the future compared to others. So a big thrust of this report is kind to, one, try to maximize the billing we have, that there exists, and try to maximize that. But the second thing is try to incentivize services to move toward what we're calling more sustainable subsidies. And that would be things like if you have a fire department that is already paid for by tax dollars, maybe the fire department could take on more EMS. If you have a hospital that's a critical access hospital, and if they become the only ambulance provider within 35 miles, they can get cost-based reimbursement for their ambulance service. So figuring those kind of details out, obviously it varies county by county on how that could be pieced together. But generally speaking, most parts of the state are going to either have a critical access hospital in the small areas or a urban fire department that could, there's one of those 2 things generally. The exception would be Fremont County and Uinta County. There's neither of those in either of those counties. So those would be the kind of the 2 areas of the state where this model would not pencil out. But generally speaking, those are our 2 main recommendations. I'll kind of get a little more depth here on the billing one, but the report really goes into a lot more detail generally. So slide 20 talks about maximizing billing potential. The idea here is that the state would put out for bid a procurement of a billing contractor, and that contractor would use the existing data within our Wyoming ambulance trip reporting system. So this is data that the ambulance companies are already submitting to us, and they would use that data to generate healthcare claims, submit those to payers, collect the revenue, and then give it back to those ambulance providers. And what that does is it reduces administrative costs because right now, ambulance providers have to submit the reports to the waters, but they also have to do the bills themselves, right? So if you can just use that same one system to generate the bills, and this is, again, hypothetical, we're still exploring this concept, that would cut out that labor of billing, of actually generating those claim forms. The state could also potentially obtain more competitive pricing if we have a lot of volume that we're aggregating together, as opposed to Albin Rescue trying to go out for bid on billing services themselves. So that may be attractive. It could lower barriers to entry, so certain services that may not have that administrative infrastructure to bill, maybe this would be attractive for them. And then it would improve the data quality of our own system. So if you're getting paid for the data you submit, essentially, that it has a strong incentive to make that data high quality and accurate. We believe this should be opt-in. We wouldn't force anybody to participate in this. We think there'd be strong incentives for those services to participate. And we could also use our own operations. As you learned today, we operate 5 facilities. We bill for patient days there. We have a laboratory that we could really improve our billing with. Those laboratory services, we have public health nurses we could potentially bill with. We could hire this contractor to do the work for the department, essentially on a revenue neutral basis. That would build a steady volume of billing volume that could be used to build upon. So we don't have a chicken egg problem of, well, how many EMS agencies are we looking at that are going to join this? Well, we don't know because we can't tell you the price. And well, we can't get a bid because we don't know the volume. So we have to start somewhere. And I think if we start with our department health volume, that lets us build on top of that. And we could add services on one at a time if we had to. But that's a recommendation that we certainly could pursue. We are pursuing it just as in the RFI stage now, just to kind of get more information on what that looks like, how much cost we're looking at to bill. That's something that does not require legislation, something we can pursue on a cost neutral basis on our own. The second recommendation is a little more intense. This is not something we would be able to do on our own. These are thoughts to think about for you all on slide 21. And again, this talks about those sustainable subsidy sources, right? So how do we kind of move the system, nudge it to kind of adopt these more sustainable subsidies, move away from volunteers if they want to, but find areas of the state, whether it's a fire department, critical access hospital, that could really pick up the EMS duties and then either receive cost plus Medicare revenue for that, or you already have a fire department that's necessary to put out fires. 80 to 90% of their calls are EMS anyway. It's a logical fit there. So these are kind of 2 options here that could be used. General fund dollars could be used to kind of target that. Maybe we have matching funds for, every dollar of Medicare revenue you get from a critical access hospital reimbursement, we can match that or something. There's the devil's in the details on how that would work, but the idea is really just try to use state resources in a very targeted fashion to try to nudge that system transformation. Conclusion on slide 22 is kind of going back to the maternity care. This is really the common problem is we have in a rural state like Wyoming, we have these high fixed costs. You have capabilities that are necessary and that don't depend on volume, whether it's nurse staffing in a labor and delivery unit in a rural hospital. They're not going to deliver many babies. There's not going to be much volume there, but you still need to have that capacity ready to go because people come in and have emergencies. They have births at all hours, right? So we pay for the capacity, but the volume is not there to sustain a lot of these services on the revenue side. So that's really a common theme between these EMS and maternity care and kind of why we asked to kind of present these 2 simultaneously. As far as levers that can address it, obviously there's payment policies, these general themes, regulation or deregulation, and then workforce supply are kind of common areas that we've talked about today. But with that, Mr. Chairman, I know that was kind of a bit of a fire hose on 2 topics. And I know there's a lot of people here eager to give their perspectives on both. I'm happy to stop here and take any questions.
Thank you, Mr. Fuchs. Committee, any questions for Mr. Fuchs or Mr. Biggs? Please, Senator Crum.
Mr. Chairman, yes. One is just a quick statement that you might look at as another advantage would be negotiating insurance contract with insurance providers. You get a larger pool, you can maybe get a different reimbursement from insurance providers might be another advantage for you. The next thing is critical access hospitals. Many of them are in financial trouble around the state. This model is built on those critical access hospitals or fire departments you talked about, and some of them have one and the other, some have both. But if we would lose that critical access hospital in a particular area where they weren't able to provide that, do you see an alternative or that type of thing? Because I do know we have several critical access hospitals that are in trouble in the state.
Thank you. Mr. Fuchs.
Mr. Chairman, Senator Crum, that's a good point. If a hospital went under in any community, there's going to be a lot of problems. I would say the situation is equally tenuous now.
I'm not sure we'd be moving to anything particularly worse, given that the fact that a lot of these organizations are on, have significant financial stress. The only point here is, from the perspective of a bean counter, and I'll fully admit that I'm a bureaucrat. We think of money, dollars and cents. The devil's in the details on how all this gets worked out. All we're trying to point out here is that there are existing revenue sources and existing subsidies that are out there that may be leveraged. Now, whether a community chooses to do that or not, it should really be up to them. We're happy to offer the technical assistance and provide these reports, but at the end of the day, it should be a community decision whether or not they choose to move their service to a hospital.
Senator Crum, you have a follow-up?
Follow-up, Mr. Chairman. At some point, I think a discussion would be worthy of having of how do we look at these critical access hospitals to make sure they're there to provide that emergency management service for those communities and for that region out there in the state. I don't know if this is the time, but at some point, I'd really like to see this committee talk about how do we protect these emergency EMS and critical access hospitals around our state? Is there things we can do legislatively that can support your model?
Okay, thank you. Further questions? Mr. Fuchs or Mr. Biggs? Yes. Senator Steinmetz.
Thank you, Mr. Chairman. I just wondered if you'd had the discussion. So, for example, in my area, we have a lot of EMS and fire departments combined. And if we are to pass the citizens initiative of a 50% property tax reduction, what impact that will have on this system, because the property taxes are what support our local fire districts, our special districts, our hospital districts in some area. Have you looked at that so that you can provide us numbers as we go into a budget session to know what Senate File 69 has done that we passed last session, and what we're looking at if we see the 50% reduction, so that we don't weaken the system irreparably?
Mr. Fuchs, please.
Mr. Chairman, Senator Steinmetz, we do have some data in the report on mills and amount of revenue collected by county. It's not as specific as I think you'd like as far as what would happen if we did X, or even how much of that revenue goes to support fire departments or EMS. It's really a general overview of kind of the tax base in each of these communities. We did a little bit of just little extra work there on looking at the EMS district, if they actually pass those 4 mills, what that would look like statewide. Those tables may help, but I'm afraid we don't have anything very specific to your question in the report itself, aside from that.
Thank you. Ms. Thayer, Representative Thayer.
Thank you, Mr. Chairman. Deputy Director, would the Department of Health support changes to legislation similar to what Senator Crum talked about to give these critical access hospital tools in their toolbox to become more sustainable for emergency services?
Go ahead, Mr. Fuchs.
Mr. Chairman, Representative Thayer, we don't have opinions, and we don't support legislation or oppose it. We are happy to execute the law.
Thank you. Further questions? Seeing none. Do you have anything else you wanted to add, Mr. Biggs?
Thank you, Mr. Chair. I think the only other couple items I'd mention from the task forces that are already in play are, as I referenced, the advanced basic life support and the basic life support obstetrics. The basic have their first group of students, we'll say. It's a one-day training underway right now, and the Wyoming Primary Care Association has supported that. That training is team-based learning. It's got didactic training as well as applied for EMS personnel and other incumbent workers in hospitals for obstetrics, as well as pre-service folks that are still in school to up their training understanding when it comes to normal labor and emergent obstetrics response. So that is happening right now. And like I said, the Wyoming Primary Care Association has been a big proponent of that and making it happen. So there are things underway to get the folks that are out there now or on their way toward graduating and getting their certifications and license out in the field with that training under their belt. And the advanced is a 2-day, the basic is a 1-day training. So that's underway, and we're looking for that to continue to grow.
Okay. Thank you very much. Please proceed. Representative Ottman.
Thank you, Mr. Chairman. Just to piggyback with that, with both of you, 25 years ago, when we moved into the neighborhood where we live, we had a volunteer fire department and an ambulance service that serviced a large portion of the county, not the municipalities, but the county. And as requirements for meeting firemen and different requirements that they had to meet for regulatory reasons, that went up, and then the grading of that all went up. With first off, just for you to keep in mind, also the critical access hospital that we're putting into Riverton, or is working on it. I had mentioned to them about possibly having the ambulance service through that, with a $38 million loan to begin with. I don't know that they can adjust their plans just like that. But so hopefully maybe that could help, because it would be a good venue. But so just to keep in mind, some of it's regulation. And so if there's ways that we can clean some of that up, I don't know. And the other thing is, would what you're offering now through this schooling, could that possibly meet some of that criteria for those people? Because that was one of the things the volunteers are saying, I don't have 14 or 18 hours a year or whatever it takes to go and do these trainings, plus all of it out of my own pocket. And so that was a big hindrance to new people coming on in this day and age. So if we can work on any of that, or if you have ideas, that would be wonderful.
Thank you. Any feedback? You're welcome to. If not, go ahead.
Mr. Chairman, Representative Ottman, I'd only note that I think the most recent development a couple years ago was moving toward using the national registry, or I forget what it's called, but national EMT licensing. So we don't have state-specific standards that they have to train to. We use national, and we have reciprocity with other states for EMTs. So that is one aspect of, I think, something that has been implemented that has been successful. But I would also note that, of course, there's a balance between regulation and the burden of that, which I fully acknowledge is a burden, and then the standards of care, right? Do you want somebody who's not trained working on your ambulance? And so that's I think the burden that we weigh, and the balance that we weigh. We're certainly happy to defer to you all as elected officials on how that balance should be struck.
Thank you. Senator Scott.
Following up on that last question, am I right in thinking what's going on with these volunteers is that the regulations are reflecting a reality that we've learned all kinds of things, professional things, that the ambulance people, the EMS people can do, and they really do contribute to life-saving and that sort of thing, and that's what's being reflected. And that increasing professionalism means that the volunteering just isn't as practical as it used to be, because you're going to need the kind of professional training that you need to get reimbursed for. People can't do it.
Please proceed.
Mr. Chairman, Senator Scott, I think we have a lot of fantastic volunteers, so I'm not sure it's entirely, I think it definitely is a burden when you have a day job and you're a volunteer. It's a lot harder to become certified and maintain currency, but a lot of people do a really good job of it. I do agree with you. I think you even see that in the licensing standards, right? It's a ladder of EMS professionals, from EMRs to all the way to paramedics, and we pay accordingly. The wage for a paramedic is much higher than an EMR because they have more skills and they can provide that life-sustaining care. So even aside from the dichotomy of volunteers versus professional, there's a whole spectrum of professional development within that career, where in some ways you get what you pay for. More advanced life-saving care requires very highly trained, skilled professionals.
Thank you very much. All right, thank you very much. For the committee and for the audience, there's a very robust report that this was just a summary of. So I don't know if there's 100 or 200 pages in that. There's a lot of information. So anybody that's interested in digging further into the details, please say that. If we got AARP and let's see, Blue Cross Blue Shield, and I'd actually like Mr. Ryman and Ms. Harfstreet to come up too, because I think they're on a time schedule. So I'm actually going to ask them. They represent the municipalities and our counties. So I'd like them to come up and just offer any feedback they want on these topics, and then we'll go from there. So we're not in public comment yet. Oh, Blue Cross, I'm sorry. I didn't recognize you. I was looking at someone else's Blue Cross Blue Shield in the back. My apologies. So if we could, Ms. House-Streets, if you would go, and maybe are you doing it for both the counties and yourself, or go ahead, please.
Thank you, Mr. Chairman. I think I'm up here for WHAM today, but Jeremiah can always lean on me for support. But thank you for the time. We're heading up to Joint Appropriations Committee, where we both have been asked to jointly present on some tax discussions, so we're on a tight timeline. But just the general comments about this whole situation and the funding gaps is that it's a shared process between all local jurisdictions, and there's major funding gaps that we're subsidizing. We have no problem providing this critical service and need to our constituents, but the lack of funding to do so and the ability to raise revenues is getting harder and harder, especially with the reduction of property tax. If there's no property tax, how do we fund special districts is just something to think about, as you know, there's new propositions on the table in the Joint Revenue Committee. And with the upgrade of Next Gen 911, we are in a working group right now looking to try to figure out how to fund that. And so there'll probably be a general fund ask of about 20 million to upgrade all of our PSAPs. And then just one other food for thought item is the patient transfer. There's some opportunity there to make some dollars, but the problem is that we're exporting patients. They're not staying. We're exporting them out of state, and then we're coming back empty. So it's kind of like a taxi service. It would help us if we could figure out how to get those patients to come back. But, you know, that's market driven. So those are just the challenges we're facing, and we're trying to be collaborative and work forward. And those are my very basic, very general comments.
Thank you very much. Any questions for municipalities? Thank you. Good luck with appropriations.
Thank you. Good luck.
Thank you for allowing that. Jeremiah, did you? Nope. Okay. So we'll get back on, well, we're not on schedule. We're nowhere near schedule. But we'll get back to our.
I'll be quick.
All right, go ahead, please.
For the record, Tom Laycock, Associate State Director, AARP Wyoming. We're a membership organization for people 50 and over in the state of Wyoming. Thanks for taking the time to consider this issue. You're not alone. We've looked at other states, New York State, Florida, Iowa, South Dakota. In fact, we've got about eight or so other states where they're already doing something because they're experiencing the same issue. So in fact, we're going to find out this year, NCSL and the National Governors Association are both taking this on as a topic. So there is going to be more information as we move forward. We do belong to the Governor's Healthcare Task Force on EMS coverage. We had a couple conversations, a few meetings about that, and there was a lot of questions about what do the people of Wyoming expect? Do they expect ambulance service? What does that look like? Are they willing to pay for it? Things like that. I don't know, was my first answer. And so what we did was we asked, how can we put out a survey on this issue? So AARP, we do have a deep bench, especially when it comes to research. And so Dr. Terry Keenan designed and put a survey into the ethos for us last year, August of 2024. 1,003 adults, not older adults, but adults 18 to 44. We wanted to reflect political ideology. We wanted to reflect age and any other demographics that we could. And so this is kind of what we came up with. It should be in your packets already. And I don't know, where you guys gonna screen it? Okay, sounds great. So if you're following along, we'll go to the executive summary on page 4. The top line takeaways are this. 8 in 10 Wyoming adults agree EMS should be considered an essential government service. We'll talk about who they think should pay for it. The good news, if you're looking for any good news, is Wyoming adults seem genuinely willing to pay at least something more for community EMS service. In fact, 83% said to be willing to pay at least something more per year for the system. So moving to page 6, and I want you to notice as you look at these pages at the bottom, you're going to see the question that was asked. That's always very helpful for me. This first particular question says, most Wyoming adults have at least heard something about EMS in the state. I asked Terry, I said, this seems really basic. What do we do? And she said, we have to establish that people actually know what EMS is, ambulance is, before we can really move forward. I'm going to ask you to skip past page 7. We'll come right back to it. On page 8, we asked the question, how concerned are you about being able to get access to EMS if you or a family member needs them? 66% of people said not concerned at all or not very concerned. I think a couple different things are happening here. I think, first of all, EMS is a victim of its own success. For years and years, we've picked up the phone, we've called 911, someone with bright flashy lights has showed up. So why wouldn't they? Second thing that I think this shows us is some information that we probably need to do a better job of talking to our local municipalities, our local EMS agencies. I received information from a very informal survey sent out by the EMS Association this last month. 31 responses. We asked EMS agencies around the state, please rate your EMS agency's financial outlook. We're going to make it a heat map. Green, we're doing fine. Yellow, we have concerns about our long-term future. Orange, we have concerns about our ability to stay open 10 years from now. And red, severe concerns about our ability to stay open 5 years from now. Of the 31 responses, and you don't have this in your book just yet, because this just came out this week, 5 said we're doing fine. 16, or 51%, said we have concerns about a long-term future. 16% said we're in the orange category. And 6 of the agencies said we have severe concerns about our ability to stay open 5 years from now. So basically 84% of the EMS agencies of the 31 that responded are saying we're in some level of financial trouble. So now we can bump back up to page 7. It's the one with all the line graphs. This question is simply, how long would it take you in minutes to get to any of these provider systems? We were just curious whether or not there was a correlation between the further away, are you more concerned or less concerned about being able to get EMS services? And we're also just kind of curious in general while we got you on the phone. How far do you have to go for specialty care? The specialty care number is something that we all kind of know, but it's nice to put an official number on it. Hospital, 8% of folks were longer than 45 minutes away. So we think we got a pretty good representation of what we're looking for there. Then bounce down to page 9, because what we do find is when someone is further away from these particular medical services, they do get more concerned about being able to access them. Page 10, we asked the question, have you or anyone in your family called 911 or another emergency number for help? Dr. Terry, upon seeing the results on this, said, what on earth are you guys doing in Wyoming, where 61% of everyone that we talked to is already calling 911? I said, we're an adventurous bunch. EMS and ambulance is far and away the service that is most called, followed by police. As Mr. Fuchs mentioned, generally speaking, you use more of healthcare services the older you get. We assume that you would see older folks calling 911 more often than younger folks. In fact, that was not the case. Page 11 shows us 65% of adults 45 to 64 made the call, then 18 to 44. Adults age 65 and over, actually, of these 3 age groups, called 911 the least. So moving down to page 12, the real meat of the issue. The question was, quote, unlike firefighting and law enforcement, EMS is not designated as an essential service, which means that counties and cities do not have to pay for ambulance service or ensure their residents have access to them. To what extent do you agree or disagree EMS should be considered an essential government service? 81% of folks believe it should be considered an essential service. You can also look at what that means broken out by political ideology. Democrats more likely than Republicans. However, at 78%, you can still see this still has bipartisan support. We also have all these broken out by age. I didn't put that in this specific one, but when we looked at the question of do you believe it should be an essential government service, once again, that 45 to 54 age range came through as being the one that thought this most likely to be or should be an essential government service. Page 13 asks, most people do believe that insurance companies should pay for emergency medical services. Once again, these are pretty generic areas or ways to pay for something like that. So I'm In a lot of cases, I do believe insurance companies do pay, but I think it's, a question of whether or not folks understand how much they pay or how they get paid in that way. Page 14, should communities pay for EMS in the same way that they pay for police and fire department services? Once again, 1,003 people surveyed. Top 4 answers are on that board. 73% say yes. Once again, Democrats more so than Republicans, but a pretty bipartisan response. Page 15 is probably one of the more interesting pages. We asked the question, some communities offer fees and taxes collected from the public to help pay for EMS systems, including ambulance, rescue squads, and hospital emergency services. How much would you be willing to pay for your community's EMS system? And these are for the folks that said, yes, I would be willing to pay something. As you can see, altogether, it comes out to about, I believe, 83% being willing to pay at least something more. You ask yourself, what good is $5 per year going to do? There's actually a lot of other states that have instituted, a couple bucks on a car tag. Colorado, for example, in the early 80s, put $1 on every car licensure that you do, and then in 2008 added another $1. Some of them go all the way up. Maryland's at between $14.50 and $21. That's a whole lot of money, especially for someone who just got the renewal requirement for his truck. So I'm a little sensitive to that right now. Nevertheless, so when you ask that question of willing to pay $5, what's that get us? Well, there are some options out there. We did ask WYDOT how many vehicles are tagged each year in the state of Wyoming. The answer is a little over 990,000. So the question being is that's something that you could consider if you're looking in the grand scheme of options that are out there available. Not a whole lot of people said they would be willing to pay more. 20%, roughly 20% in the total said they'd like to not pay any more. So implications, people understand what EMS is, though they may not understand the financial realities of where EMS is within the state of Wyoming. And really, we find that people do believe it should be essential, and 8 in 10 are willing to pay at least something more, with 3 in 10 saying they'd be willing to pay $50 per year or more. Under that, we've just got the methodology. Who'd we call? When did we call them? And who did the calling? So that said, I'd be happy to answer any questions that you've got. I did want to make a pitch for the primer that Franz put together with the Wyoming Department of Health. It's a big document, but it's got information that's really localized to each of your communities, each of your counties, letting you know how many runs it would take, for example, to pay for itself. And that's really one of the questions that EMS has long had is it a business or is it a service? And that's something that we as a state really kind of have to figure out what that looks like and then sort of take concrete steps from there. So that said, happy to answer any questions.
Thank you. Mr. Laycock, any questions for Mr. Laycock? Questions? Questions? Seeing none. Former Representative, current Senator Hutchins.
Thank you, Mr. Chairman. I'm listening to this, and I used to be in EMS in the 90s, and in a pretty rural state, not as rural as Wyoming. And it just seems to me that, I don't know who you sent your survey out to, but you were comparing us to Maryland. I lived close to Maryland. Colorado, I lived close to Colorado. There are a lot of people in those states. More than, you can drive down like maybe 20 blocks and get as many people that are in our state, to exaggerate it. For me, when I campaign, I go out into the county, and most people don't want to be bothered by anybody. And I just can't see someone saying way out in distant counties, I expect EMS to come here. And I expect them to be here in 6 minutes, 9 minutes. I live maybe a few miles out of Cheyenne. And I'll tell you what, I wouldn't expect EMS to ever come out there in any time period to be of any value. Either someone's gonna get me to the hospital, or via their vehicle, or you're just not going to make it because you just know they can't come out that far.
Senator Hutchins, do you have a question in this for the presenter?
It's coming.
Let's do that, please.
I know. But we're rehashing this over and over and over, but the practicality in my mind of an expectation to get EMS to come out to where I am and pay for it, when in all my years of living, I've never called EMS, thank God. But tell me, is this really a good expectation for Wyoming to be able to get EMS to everybody in the state when they want it for $5 or $10 more?
Thank you. Go ahead, Mr. Laycock.
Thank you, Mr. Chairman.
Mr. Chairman, Senator Hutchings, appreciate the question. I think our survey data would suggest that folks do expect and would like it to be considered an essential service. Now, I grew up on a farm in Iowa. We knew if something happened, we're out there a ways, right? Now, if something happened, we're going to throw someone in the truck, but we're also going to call 911, and we're going to make sure Connie Hansen meets us at the Olin Corners. Okay? We do expect that level of medical service, whether it be volunteer, whether it be professional in the city where we live in now in Cheyenne, but I think it's a tough sale. I think people understand if I live 50 miles out of town, I'm a little bit on my own, but I don't think that means that they don't expect any help whatsoever.
All right, thank you very much. Further questions? Seeing none. So we've kind of bouncing back and forth. Obviously, that was on EMS. Blue Cross Blue Shield, I think, just provided us a handout today. So this will be more on maternal care gaps and your things you're doing there. So we'll take that. And then folks that are interested in giving public comment, start thinking about your comments. Based on the number of people that I saw raise hands, we're probably going to go with, in the public comment period, we're probably going to go with about 3 minutes a person. So please be succinct in what you'd like to offer. We'll go from there. So Blue Cross Blue Shield, please introduce yourselves and proceed. This will be on maternal care and the press release or the materials they provided. Thank you. Go ahead.
Thank you, Chairman, members of the committee. Kelsey Prestisator with Blue Cross Blue Shield, and I have with me today our Director of Population Health, Amy Skazwak, and one of our medical directors, Dr. Lisa Brandis. And we are very excited to share some new maternity programs that we will be rolling out here in the state of Wyoming to address the access to care gaps that the committee is discussing today. Thank you.
Perfect. Please proceed. Whoever would like to, introduce yourself and proceed. Thank you.
Thank you, Chairman Barlow and committee. My name is Amy Skazwak. I am the Director of Population Health at Blue Cross Blue Shield of Wyoming. And coming up on July 7th, we will be opening a maternity program at Blue Cross Blue Shield of Wyoming. It will be called Special Delivery, available to the majority of our members. With that being said, it has a couple of components that we think are unique and really talk to some of the issues we've heard today. So one is we will be introducing a provider reimbursement program that increases the reimbursement providers receive for a first trimester visit with members. Currently today, they are paid for global maternity, meaning that there's a bundled payment similar to what Medicaid spoke of earlier today. This will pay on top of that bundle. So it's an additional reimbursement to our providers. The reason that that's so important is most members are unfortunately not calling their insurance company to tell us that they are pregnant. And so we're unable to provide them with additional resources. So this partnership allows us to help engage the member community. And that first engagement that we'll be entering into is offering prenatal vitamins through a subscription service to our members. So that subscription service will be delivering prenatal vitamins to their front doors for the continuum of their pregnancy. What that allows is in our communities who may not have access to prenatal care or prenatal vitamins, it removes that barrier. It also allows our members to receive those at no cost. So that helps to incur utilization and make sure that they're starting off that pregnancy well. After that, we are introducing a partnership with a vendor named Marani. Marani is a vendor who offers remote monitoring for pregnancy. It is done for pregnancy only through this company. And what that allows our members who don't have access to care or those that are high risk to be monitored remotely and all of that data provided to our OBGYN community or our family practice physicians. So that will allow them to augment the care, so not replace our providers, but give them additional data on the patients that they're already seeing. In addition to that, we are offering a lactation support vendor who will be available to our members 365 days a year, 24 hours a day. This is again to supplement the provider network within our state. So for anyone who's ever had an infant or newborn, you may have problems at midnight, weekends, holidays, when our providers may not be available. We want to make sure that our members have additional access, again, above and beyond what's in their community. This also speaks to our communities who have no access to lactation support. In addition to that, we also are starting an educational campaign on breast pumps. So many members are unaware that breast pumps are actually paid for by your insurance plans. And so we want to make sure that our members have access to those and reimbursement. Those are paid for at 100% of an allowable rate. And then we also want to bring a lot of attention to postpartum depression. So we want to make sure that we have availability of postpartum depression screenings as well as counseling services. So we are adding an additional vendor to our network. They are called MD Live. They are a telehealth vendor who offers postpartum counseling as well as screening. So that can be done in your own home. Again, that is to supplement our network, so we know that there are communities around the state who may not have traditional providers or those that specialize in postpartum care and may need additional access. And so again, this program kicks off on July 7th, so just a couple weeks out. If any of you would like additional information, we do have some informative webinars coming up that are for our provider community, and we would be happy to extend that invitation to any of you that would like to attend and hear more about those details of the program. And real quickly, I will hand it over to Dr. Lisa Brandis, who's our clinical lead, who helped bring this to shape to talk about why this is so important to us.
Please proceed, Dr. Brandis.
Thank you, Mr. Chair and chair members, or committee members, sorry. I am Dr. Lisa Brandis. I'm a family physician, a wide spectrum of care over the 30-plus years of my career, including maternity, but care in ERs and hospitals in small communities in Wyoming as well as the larger communities. I've seen firsthand how big this issue is and how we need to work on it. I would emphasize that this is the beginning of our program, not the end. We are continuing to explore things that we can do to be part of the solution for the state of Wyoming. We realize this is a small start, if you will, but it's a crucial thing for our state, not only for the healthcare, but also for our economical development, because I don't think that young families are going to move here if they can't get maternity care. So be happy to stand for questions now.
Thank you. Any questions for Blue Cross Blue Shield? Any questions? So, how many, if I could, how many covered lives does Blue Cross Blue Shield have? Just approximate right now in Wyoming. Thank you.
Thank you, Chairman Barlow. Over 100,000 right now within the state of Wyoming.
Thank you. Further questions? Further questions? All right. Thank you very much. We appreciate you being here. Thank you for your work on this. All right, so let's do maternity care first. So folks that want to provide any public comment on maternity care, let's fill up chairs here. So please come on up. Thank you for being here. Just like before, if you'll introduce yourselves, and if you're representing someone, great. And if you're just here on your own behalf, please proceed. So thank you. We'll just start right here. There you go. Green light. Go.
Okay. Great. I'm going to be discussing maternal care deserts. I guess we already established that, but thank you, Chairman Barlow, and thank you, committee members, for focusing on this incredibly important topic. My name is Britt Borrell, and I'm a private citizen who was born and raised right here in Casper. But I've also lived in other states, but it wasn't until I moved back to Wyoming at the end of 2021 and discovered the exodus of reproductive care providers in our state that I became really passionate about this issue. Upon returning home, when I needed to seek routine gynecological care, not even concerning a pregnancy, I was shocked not to be able to find a provider to see me for 6 months, except for Wellspring, an invaluable resource in our community, which this committee has made numerous attempts to shutter through legislation. And that attitude, I'm afraid, is a major contributor to the maternal care deserts we are currently facing. A full third of births in this state are covered by Medicaid, and the state legislature's refusal to expand Medicaid reimbursement was a major factor for 4 birthing facilities that once served our rural communities to close down completely over the last 12 years. It is also worth mentioning that we have little hope of attracting qualified OBGYNs to practice in our state when your colleagues are so focused on restricting abortion access that providers cannot navigate the legal landscape to provide the full standard of care to their patients. The full standard of care includes abortion, and when you attack one aspect of reproductive care, you are attacking the entire system and patient safety at once. I would also like to add, kind of addressing Representative Yin's question earlier, I think that it's hard to attract OBGYN residents who are also trying to specialize to come practice in our state as well, if they can't actually practice the full standard of care. I read through a memo provided by the Governor's Task Force on Maternal Care Deserts, though what I read mentioned some different ameliorating solutions than were mentioned here today, such as expanding Medicaid coverage for telehealth. And I think that I agree that this type of expansion in coverage would be an improvement. And if we do that, we should be sure to include spontaneous abortion, also called miscarriage, and medication abortion support, because a lot of people end up going to the ER when they're just experiencing unfortunately normal symptoms of miscarriage, but they're just not aware. And so if they had telehealth coverage, we might actually save on emergency services there. But I do believe that more impactful actions you can take to protect patient safety and outcomes are to stop focusing your energy on stripping reproductive freedoms from your constituents, fund Title X and community clinics in our state, and finally to regulate anti-abortion centers, which are currently not required to be licensed, so that they must, at a bare minimum, adhere to HIPAA laws to protect patient privacy. Again, thank you for your attention to this vital matter for our state.
Thank you very much. We'll just go down the line, please. Welcome.
Thanks. Hi, I'm Elizabeth Erickson. Thank you,
Elizabeth
Chair-
Erickson?
Yes.
Yep, please go ahead.
Thank you, Chairman and committee people, for being here today. I'm also going to talk about the maternity care desert. It has come to my attention that relying on crisis pregnancy centers or anti-abortion centers is something that's been looked at. I will say that there are 11 crisis pregnancy centers in the state of Wyoming. The trouble is, here in Wyoming, we preach the code of the West, and one of those pieces of the code is honesty. When we look at anti-abortion centers, also known as crisis pregnancy centers, they are anything but honest. These centers seem to have the potential to fill the maternal health desert that has plagued Wyoming. However, their tactics are harmful to pregnant women. These centers claim to be crisis pregnancy centers, recognizing the crisis that can happen when a person finds themselves pregnant and does not want to be. These anti-abortion centers manipulate women using inaccurate information to shame and persuade them to continue their pregnancy, even if it is dangerous or unwanted. Anti-abortion centers come with misnomers like true care, with the intent to create trust to the people seeking their services. Their care is anything but true. The clinic staff often purposefully overestimates the age of the fetus and will tell a pregnant person that they are too far along for an abortion, or they will spew false claims about the danger of abortion. Anti-abortion clinics do not adhere to state and national standards for healthcare facilities and are completely unregulated. It is not honest for anti-abortion centers to present themselves as legitimate healthcare facilities. It is not honest for these centers to abstain from HIPAA regulations. This is not honesty or integrity. This is manipulation. If we want to solve the problem of the maternal healthcare desert of Wyoming, we need to allow real physicians to practice the full scope of reproductive healthcare. We need people to be able to access the full scope of reproductive healthcare, and we need maternal healthcare that is really true. Thank you for your time and consideration.
Thank you. Appreciate that. We'll just go down. If there's other folks who want to testify as people leave, come on up, please. Please, sir. Your name? Yep, green light, and pull it a little closer to you. You're kind of sitting back a little bit. So.
Thanks, Mr. Chairman. I was actually going to wonder if I could follow Mr. Beveridge, or Dr. Beveridge's comments first.
Yep. Please introduce yourself for the committee and proceed.
Thanks, Mr. Chairman. My name is Dr. Jacques Beveridge. I'm a OBGYN from Cheyenne, Wyoming. I am, I guess, a few representations. I do sit on the healthcare task force, specifically the maternal health committee. I also am an adjunct clinical faculty at UW Family Practice in Cheyenne and help train them on their obstetric rotations, and certainly have a heart for these moms who no longer can deliver in their communities and potentially losing their ability to deliver their babies at home. I had a few points that I simply wanted to make. The first would be for your favorable consideration of increasing Medicaid payment. You've heard that a few times today. We've heard from the Department of Health on some ways to do that and their ability to do that. And that, I believe, would go a long way in ongoing retention and recruitment of docs who can come to the state or stay in the state and deliver babies. The second would be an update on the UW Family Practice. Last summer when I spoke to the committee, which was a number of different folks, but we talked about some potential solutions, and one of those was possibly bringing an OB fellowship to the state or starting an OB track at the Cheyenne UW Family Practice residency, mirroring what we're doing or what they do here in Casper. And the good news is we've achieved that. That is about to kick off. That came at the prompting, really, of the task force, and then in communication and work with the UW residency overall and with the program in Cheyenne. We have now a plan in place. We have residents selected that will be on an OB track starting in July when they start their second year, which means our real goal is for them either then to be able to get into an OB fellowship following residency or an FPOB fellowship, or simply to go get a job, hopefully here in the state. It's one of our ideas or criteria for their selection. And we have at least one of those residents already being and getting interviews in state for when he graduates here in 2 years. And then the third item I would point out is to say that WWAMI matters. I am the old school representation of that, born and raised in Wyoming, left, came back. I've practiced my whole career here. I practice around tons of WWAMI grads, and that program brings residents back to the state to practice medicine. I would also say our family practice residencies matter. They are bringing even outsiders in. I hate to call them outsiders, but we have a number of docs in the state that came to do their residency here, and they stay and they practice. And I think now by expanding this OB track to Cheyenne, we're going to have additional FPOB residents staying in state and providing services. And so I would just ask for your favorable ongoing support and consideration of those programs in your role as legislators, including the graduate medical education we heard about today, that kind of funnels or runs through the residencies and the university. And I would close. I went a minute over, I'm sorry, but I would stand for any questions if you have as relates to those couple of things I mentioned.
Excuse me, Co-Chairman, question for Dr. Beveridge?
Beveridge, yes.
Thank you.
Thank you, Dr. Beveridge. I'm not sure if you were here during the governor's presentation, but there were several policy options that were presented to us, none of which you've proposed in your three proposals here, but I'm curious what your thoughts are regarding two of the suggestions proposed, and I believe you're familiar with them because you were on the task force. Malpractice risk pooling and quality improvement, and then malpractice tort reform. And I know that the second has been addressed before. Just your thoughts.
Yeah.
Go ahead, please proceed.
Thank you, Mr. Chairman, Co-Chairman. The tort reform, the state has looked at caps, and we talk a lot about caps, but there's a number of other paths to take as relates to tort reform beyond that, and things that we could look at to really help with access in our state, and insurance is a significant one. And what was the other one? The pooling of risk. That one I'm not as familiar with. I don't know if someone else on the committee that's here would want to comment on that one, if it's insurance pooling or what have you.
Okay, thank you. Go ahead. You wanted to go second, so go ahead and introduce yourself.
Thanks, Mr. Chairman. My name is Dustin Main. I'm a pediatrician here in Converse and in Natrona County with Memorial Hospital, Converse County. I do inpatient and outpatient pediatrics at both hospitals, at Wyoming Medical Center and at the hospital there in Douglas. I'm here representing the Wyoming chapter of the American Academy of Pediatrics, as well as the Wyoming Medical Society. And just wanted to point out, and nothing big, and should take just a minute, to remind that when we're building up and having concern and bringing in obstetric care, that we don't miss or lose an opportunity to also bring in pediatric care at the same time. As we bring in especially more complex cases into the state, that does require more complex care for the infants as well too. We need to really make sure that we're focusing on that infant care as well. We have really good relationships with the surrounding neighborhood hospitals. I primarily work with a lot of the hospitals out of Denver. They're great. They're really eager and helpful with giving us information and guidance and accepting our patients. However, especially with winter, with travel, that can often be very challenging, having to do flights for life down to Denver, especially with mother not being able to travel, and separating families can be challenging. So as we work to build and replace what we have for maternal care, I just want to remind everybody not to forget that aspect as well.
Thank you very much. Thank you. Ladies, thank you very much. Yep, go ahead. There's more folks who want to speak on this one. Please come forward. Go ahead, please. Introduce yourself.
Thank you, Chairman and members of the committee. My name is Melissa Behringer. I'm a citizen here in Casper. When the Supreme Court overturned Roe v. Wade, my stomach sank because I was concerned lawmakers would not stop until the only way a woman would be able to access this care would be through dangerous means, or by spending a lot of money to travel to states that respect women's bodily autonomy. Many of the laws that have been passed are keeping our state from hiring care providers that want to care for their patients, utilizing the most scientifically and evidence-based practices. This type of legislation is keeping young families from moving to our state and causing others to leave. People that are vehemently anti-abortion want to prevent abortion at all costs, but I'm not sure that they put themselves in the shoes of others. Women seek this care for a myriad array of reasons, but the real reason is because they have thought through their options and landed on the one that makes the most sense for their individual lives. When the Life is a Human Right Act passed our legislature, I was beyond alarmed at the language of the bill. It states that life begins at conception and changes the scientific term embryo to unborn baby. Perhaps misguided pro-life lawmakers did not think about how by infusing religious ideology into our laws, these laws end up demonizing people like me that relied on science to have children. Our only option for a viable pregnancy was to utilize in vitro fertilization. My husband and I were fortunate enough to have a successful implantation of 2 embryos in 2007, and our awesome sons are now 17. For 3 years, we kept the other 8 viable embryos in storage as we weighed our family planning options. When we decided that we wanted to focus our energy and resources on our sons, we donated those 8 embryos to science. When this law passed, I facetiously said, "This infers that we murdered 8 children." With the continued passage of more and more oppressive laws that are not based in science, I'm concerned that donating embryos might be something that is criminalized in the future. The first IVF baby was born in 1978. For 45 years, we recognize this science, and it has benefited many people and created many lives. Today, I come before you because we need to attract care providers to our state, and many of the laws passed in Cheyenne are doing the opposite. Think about all of our citizens and all of the different circumstances that we face. Laws should not be made just for those that are in power. Laws should be made in practical ways that benefit all of our citizenry to the best of our abilities. And when science and progress demand we change our laws so that they continue to benefit our society, that is when we change them. We do not make laws in this country to benefit one religion over another. We demand laws that are rooted in science and what is right for our society, what is right for our women and our children and our men. We all deserve for our citizenry to have quality care. Thank you for your time.
Thank you very much. 2 17-year-old
Yeah,
boys?
they're boys, yeah.
I'm sorry. Just kidding. You're very blessed. We're glad. We're so glad. Do they go to high school across the street here?
They don't.
They go down the other end of town? Okay, great. Go ahead. Please.
Mr. Chair and members of the committee. My name is Sarah Morey, and I am one of the co-owners of Earthside Birth and Wellness, Wyoming's first freestanding birth center located in Cheyenne. Our facility employs licensed midwives who provide care at the birth center. We offer out-of-hospital births for healthy, low-risk women, delivering midwifery care in a centralized location that meets all state regs for midwives and birth centers. We are proud to have recently received national accreditation from the Commission for the Accreditation of Birth Centers. We strongly believe that expanding access to midwives and birth centers can help address Wyoming's maternal health crisis. Midwifery care provides excellent outcomes at lower costs and often offers a compassionate, evidence-based approach to maternity care. Our center has been in operation now for 2 years, and during that time, we've learned a great deal. One of our biggest challenges has been navigating reimbursement. We have low provider rates from Medicaid, limited recognition by private insurers, and difficulty receiving facility fee reimbursement. As the governor's task force has rightly identified, midwifery care is part of the solution. Wyoming already has really great regulations around midwifery care, and in Wyoming, licensed mid-cares are recognized as autonomous providers. Most midwives attending home and birth center births are certified professional midwives and are licensed by the state. Unfortunately, licensed midwives are underpaid, and birth centers across the country struggle with inadequate reimbursement. Here in Wyoming, we are now facing the same issue. For example, even private companies do not reimburse CPMs, which are licensed midwives for home or birth center births. Medicaid in Wyoming does reimburse us, but only at 70% of an unsustainable provider fee. We're in active negotiation with several private insurers as well as Medicaid. Medicaid Wyoming has expressed interest in reimbursing for facilities fees, which is really encouraging. However, we have one interesting obstacle right now. The taxonomy code for birth centers, which is federally recognized code, is not currently available in the Medicaid Wyoming enrollment drop-down menu. This is simply because Wyoming has never had a birth center before. We're now being told that adding this code may require legislative action. If that's the case, we urge a swift resolution. We currently serve a large Medicaid population. 35 to 40% of our clients are Medicaid. Currently, as small business owners, for each Medicaid birth, we absorb a $4,000 loss. This is not sustainable. Finally, I want to draw your attention to Section 2706 of the Patient Protection and Affordable Care Act of 2010, which states that a group health plan and a health insurance issuer offering group or individual health coverage shall not discriminate with respect to participation under the plan or coverage against any healthcare provider who is acting within the scope of that provider's license under applicable state law. This provision prohibits payer discrimination based on a provider's licensure when they are acting within their legal scope of practice. This protection applies to both licensed midwives and the birth centers. This means licensed midwives should be covered at 100% as well, and birth centers should be receiving sustainable facility fees. Thank you for your time and thoughtful consideration.
Thank you very much.
Mr. Chairman,
Yes, please.
could we
Yeah.
bring up Director Johansson to cover some of that, the issues brought up in that last testimony, or should we wait?
Let's keep going through public testimony. We're actually probably not going to take any action on bills tonight because it's going to be a late night. So if we have action, maybe we can get some feedback from Director Johansson before we take that action tomorrow. Josh, Mr. Haynes.
Thank you, Mr. Chairman, members of the committee. Josh Hannes with the Wyoming Hospital Association. I'll be very brief, and my comments will be specific to maternal health, but they really apply to the EMS issue as well. the Department of Health laid out for you what I think very accurately was the issues and the challenges that we face in both of these areas across the state, so I won't belabor any of those points. I would say that we, the Wyoming Hospital Association, participated on the Governor's Health Task Force on maternal care. We participated with the EMS. We helped develop some of these recommendations. We're supportive of a great number of a number of them. And if this committee believes that they're not okay with the current state and where we believe it's going to go if there's no intervention, and you believe that the state has a role to play in doing better, then I think there's a number of valuable recommendations that have been presented that could take bill form. We would be supportive of those. We'd help the committee work through the details as Mr. Fuchs laid out, that the devil is in the details. We would be happy to participate in those. And I just think that if there's an opportunity here to move forward, create a bill draft, work through the interim, and none of these are going to solve the problem outright. But if they're going to make positive improvement, and we can test things, right? I mean, we can take time to see if they work. And we would be supportive of that effort. So I would stand for questions. Mr. Chairman, I'd also say there's another issue that we worked with Representative Thayer on. I get the impression this is maybe not the appropriate time to bring that up. It's not specific to maternal care, but I'll lean on your guidance for when that might be the time.
Yeah, so I think based on where we are on time, and because it is a little separate topic, I will take it up maybe tomorrow in our, just into the general comment period and have that discussion. It's about bankruptcy in hospitals, county memorials, and the inability to do that. So just give the committee a heads up. Wasn't actually part of the agenda. It's been brought to us in the last couple of days, but I think it's worthy of looking at. So thank you. All right, Ms. Davis.
Good afternoon, committee. Mr. Chairman, my name is Jen Davis. I'm with the Wyoming Primary Care Association. I'll be brief. I think a lot of great things have been discussed already. And as Mr. Hannes just mentioned, that I think there are some great options laid out in front of you. We've had these discussions on these two topics for considerable amount of years. And I would implore all of you that I think it's time we take some action, even if it's little pieces to start to see if we can make a difference for our state, because our women and children deserve it. And so with that, I want to just give a little bit more detail on a couple of the recommendations that came out of the task force that are also in motion right now, just so you all have that for consideration. As Mr. Biggs discussed earlier today about some of the training, the Wyoming Primary Care Association, in partnership with the Department of Health and with AWON, which is the the Association of Women's Health Obstetrics and Neonatal Care. They're starting a new chapter here in Wyoming that is being headed out of Teton County, out of St. John's, that is really focusing on how do we better care for maternal health in Wyoming and get better maternal outcomes. With that, we are starting a program that is called OPS. It is Obstetric Patient Safety. That is really a community training that is offered to all care providers, whether that be midwives, physicians, nurse practitioners, EMS providers. It is meant to be a wraparound training within the community for them to develop an emergency plan, especially in our maternity deserts for labor and delivery. So for instance, in Evanston that just lost their labor and delivery services, it provides an opportunity for these entities to all come together and discuss how they are going to address women in their community that are pregnant, how to triage them, what to do if somebody shows up in their ER there and is in delivery. What is the safe alternative that they have? Is it to transport them ground? Is it to transport by life flight? It really is an opportunity for communities to come together and help problem solve how they help women in their local communities. That first training will take place in August. The second will be in October. So again, hopefully your counties will get involved in this, because it really is critical. Even if you have labor and delivery services, all of our providers need to know what they're doing in their county for response, so that quite honestly, we save more lives, both women and infants. The next thing that I want to mention that was also a recommendation of the task force was establishing an ECHO through the University of Wyoming. So we're in negotiations right now with the university about standing up a primary care ECHO for OB, which would include anybody doing maternal care, so our FMOBs, our OBGYNs, and really an opportunity for them to come together and do trainings collectively, but more importantly, talk about cases like maybe a family practice OB says, gosh, I saw a patient who had this. This is what I did. Was that appropriate? Or what should I do the next time? Really give an opportunity to build capacity and collaboration among our providers in Wyoming. So we will be hopefully kicking that off here really soon. And Dr. Beveridge, that was up here earlier, has been really instrumental in those conversations, and just really want to give out a shout out to him. He's a very busy man. As you know, we have a severe shortage of OBGYNs in this state, and he has taken a lot of his time and effort to put forward and be part of those recommendations in front of you. And if anybody knows the situation, it's him. So again, I think that it's really valuable that we've had him participate. And with that, I'll stand for any questions.
Thank you. So Ms. Davis would have been the one that actually initiated a lot of this work that was reported on today. So thank you for your work with the governor's office at that time. All right. Mike Lehman, please proceed.
Thank you, Mr. Chairman.
You can introduce yourself too, if you like.
Thank you, Mr. Chairman, members of the committee. My name is Mike Lehman, representing the Catholic Diocese of Cheyenne, and been in this position for about 10 years. And I am sensitive to folks' concern about, religious imposition on legislation, that type of thing. And I'll say the last 10 years, whether we're advocating on behalf of immigrants, the working poor, or the preborn, it's certainly not an effort on our part to impose, but to take part in the conversation, highlighting human dignity, but also our responsibility to the common good. Sometimes the legislature likes what I have to say, and many times they don't, and they proved it over 10 years, and that's okay. To be able to be a part of this process, very much appreciated. Abortion is one of those issues to me, in my mind, when I think about it, is it highlighting, bodily autonomy, the individual rights, and balancing it against the common good. Probably there's no other issue where those two things come so closely, and that's why it is difficult. But to me, that's why it needs to be something that we have good conversations about. Sadly, in front of committee and in committee debates, that's when you actually hear the best arguments on both sides of it. We're not doing a very good job of that in our culture, unfortunately. And so I say that to express the seriousness with which I'm approaching this and throwing this out. I do want to kind of highlight one study that was released in April, particularly dealing with this OBGYN shortage, because it's been mentioned before, we're not alone in this. There was a study in April, and I will share it with the committee and anybody that would, from the public that would want it, but I'll just highlight the key points to it. So the question was, how have practice locations of obstetricians and gynecologists changed since the Dobbs decision in June of 2022? And the findings of this study, in this cohort study of 60,085 OBGYNs, the number of OBGYNs did not significantly change across policy environments, increasing by 8.3% in states where abortion is banned, increasing by 10.5 in states where it is threatened, and 7.7 in states where it is protected after the Dobbs decision. So the differences, depending on the state policies, were kind of null there. So, and the meaning of this in the study, although the Dobbs decision has increased physicians' concerns about providing reproductive health care, there were no observed disproportionate changes in OBGYN practice locations as of 2024. I just wanted to share that, and I would be willing to share that with the committee, and again, anybody that would be interested in looking at that study. With that, I would stand for any questions.
Thank you very much. What was it? That was 2024 or 2025 data?
The study?
Yeah.
It was, well, it just went away on me.
I think
it was April of 2025.
25, okay, thank you very much. Ms. Moses, I believe I recall your name. Thank you. Go ahead, please proceed. Introduce yourself.
My name's Rachel Bozis. I'm here as a private citizen and the new mom of a 5-year-old, 5-month-old, excuse me.
I was going to say congratulations on the 5-year thing.
Yes, no. I am very tired, as you can see. But I was surprised to learn of the Department of Health's comments that even here in Casper, which is where I live and where I had my baby, that this isn't considered a maternal desert. There are currently 3 OBGYNs who are accepting patients. They are all full, so I don't believe there's an OBGYN who's taking a Medicaid patient, so they can go to UW Family Practice, which is an outstanding facility. But I had a complicated pregnancy, a high-risk pregnancy. I had to go to Denver for a procedure. And I can't imagine how much more challenging it would have been had I not had the continuity of care of seeing the same doctor over and over again. So I just wanted to remark that even in Casper, where it's supposedly not a maternal desert, we're going to be having issues very soon.
Okay, thank you.
Thank you.
Appreciate it. Congratulations on your 5-year-old.
Thank you. I have pictures if anyone wants to see her.
You get 16 more years and you'll have a 17-year-old. All right, please introduce yourself and proceed.
Hello, my name is Valerie Berry, and I did not receive permission from the state executive directors of pregnancy care centers to represent them, nor did I ask my board of directors at Life Choice Pregnancy Care Center to be here. So I am representing myself as a private citizen who happens to be an executive director at a pregnancy care center, if that's the long way to introduce myself. I wanted to share a couple of things. First off, thank you so much, Mr. Chairman, and to the committee for providing an opportunity for those that were not prepared to speak today that felt the urgency to present ourselves. And so I appreciate that you've allowed me to have this time. My compassion is extended to those who have suffered with loss of pregnancy or difficulty in becoming pregnant, or who have had difficulty receiving appropriate medical care. I do have great anticipation for what Blue Cross Blue Shield is bringing to the table and the opportunity to provide access to motherhood. Wyoming pregnancy care centers are all throughout the state. There's one in Casper, Sheridan, Cheyenne, Etna, Cody, Powell, Riverton, Rock Springs, Gillette, and Pinedale. You may recognize some of those cities that have been proclaimed as medical deserts, and there are pregnancy care centers there. So we support mothers and fathers who live near maternal health deserts in their early pregnancy needs. We do not financially benefit from our patients' care. Everything that we offer is free to them. Our patients include those who are marginalized in our community, mothers with substance abuse, and our staff has also been trained to watch for signs of sex trafficking or labor trafficking within our patients or our clients that come to our center. At my personal center, we provide well woman exams, adoption information, housing referrals, maternity and infant supplies, medical referrals, parenting education, after abortion care, pregnancy options information, abortion aftercare, I already mentioned that. But they're basically with pregnancy needs, when somebody becomes pregnant, there are 3 options for them: abortion, parenting, or adoption. And so we do provide coaching for that, all 3 options. We also provide pregnancy tests, rapid testing for STD and STI treatment. We have date representation of ultrasounds on site. And we have conversations with Plan of Safe Care of how we can support the mothers and that program. Our medical team consists of a medical director, a retired doctor of obstetrics, family nurse practitioner, 2 registered nurses, and a doctor of chiropractic. So we are a medical clinic. Our patients and clients have full autonomy in the direction of their appointment. We are permission-based, and the patient can accept or decline what we present to them. So we do not force anybody to receive any of the information that is provided. We ask questions, and they can say yes or no to what is available. We have great relationships with our community partners. We receive referrals from Public Health, University of Wyoming Family Practice, and many of the women clinics in Cheyenne. We are conduits to finding support for individuals to find care not only for maternal health, but substance abuse, homelessness, trauma, and making appointments for them and giving referrals to community partners that can provide services they critically need. Thank you for your time. Any
Thank you very
questions?
much. Thank you very much. Appreciate it. Go ahead.
Thank you.
Mr. Chairman, my name is Rush Rickman. I am now, besides a private citizen, I am the president of the Natrona County Right to Life. I am an active volunteer at True Care, and since True Care, our local pregnancy resource center, was mentioned, I want to make a couple quick comments. First of all, pregnancy resources are the greatest threat to the abortion industry. That is why when the Dobbs decision was made, there were attacks, there was harassment. True Care has been in this community for 38 years. There's a medical director, there's nurses, they have open houses. Anybody want to go there and see? As I mentioned, there's 11 pregnancy resource centers in the state. They do a great job. 100 different voluntary free services, either directly or referral. A few years ago, a company out of Washington, D.C. came here to prove that they could do abortions in Wyoming. And so the attack on the pregnancy resource centers will continue. Everybody has their right to free speech. And the pregnancy resource centers in other states that have faced legislation requiring these centers to refer for abortions is something that we should not do in Wyoming. And I urge the legislature to retake up the legislation that didn't get through, because you had a lot to do last session. I urge you to pass legislation to protect these wonderful resources in our communities.
Thank you very much. Does anyone else want to testify on this maternal care? Anyone else, please come forward. How many do we have online? I should have given everybody a heads up. Part of the reason I'm trying to keep people moving is because we have online folks as well. Okay, thank you. Go ahead, please, ma'am. Welcome. Please introduce yourself.
Mr. Chairman, members of the committee, my name is Jane Ifland. I live in Casper and have for the last 40 years or so. I didn't come here to make any particular change at all. And I would like to bring forward the fact that if there are attacks on facilities in my town, I would say that the arson that was perpetrated against Wellspring, the abortion clinic in our town, must be primary in consideration of whether there are attacks on facilities. I would also point out that none of us at all can know what is in the heart, the mind, the body of someone who's pregnant. And I would suggest that there is no more intimate choice than what that pregnant person is going to do with her body. And for that reason, I would suggest that we all
Please.
Stay out of it. Thank you for your time and attention. I'll certainly stand for questions. Let's have them.
Thank you very much. We appreciate it. Thank you. All right, let's have who's online, and then EMS folks, queue up.
First is Dr. David Lind.
All right. If you can hear me online and you've signed up to speak at this portion, please be ready to dial in. Please introduce yourself, and I'm going to start a timer.
Unmute. My name is Dr. David Lind. I'm from Cheyenne, Wyoming. I'm a retired OBGYN. I practiced my whole career in Cheyenne. I'm Cheyenne born and raised, participated in the Wyoming contract programs, came back and practiced obstetrics for 33 years. I certainly would like to emphasize all the comments that Dr. Beveridge had made on how important it is for us to continue the family practice residency programs and to be able to continue to teach residents how to do obstetrics. I was passionate about that in my 33 years, and I participated wholeheartedly in helping the residents learn obstetrics. Now that I'm retired, I spend my time at the pregnancy center in Cheyenne. I volunteer my time every Monday doing ultrasounds and advising young women as much as I can on the issues of pregnancy that they would like to know about. I think that we provide in the pregnancy centers something that people don't really see. We actually act as a referral for each one of the programs in Cheyenne, or all the different practices in Cheyenne. Will refer patients to us for early ultrasounds and designation of their gestational age, and help to be able to act in a manner to supplement the care that's being provided without adding any charge. We do the work that we do for free. Then additionally, we provide a lot of services beyond delivery. I think that giving the pregnancy centers the rap of being overly religious is kind of a dodge to what we really need to know. We're really not here to push religion on anybody. We're not here to condemn anybody. We're here to help the women that need help. And for that reason, I think that the residency program should be continued. I think we should make sure that that's a big emphasis, and hopefully we'll be able to get the OB fellowships, which will allow family practice residents to feel more able to take care of their patients in rural settings, and hopefully be able to do more recruiting. And with all of that, I would stand for any questions that the committee would have.
Thank you very much. Thank you very much. Who's up next?
Next is Tony Decklever.
Tony Decklever. If you can hear us, please join us. I've definitely given you a timer, Tony. I know you.
Going here. Goodness, I can't make I can't make my camera work. I'm so sorry. Oh, never mind. Okay.
Please proceed. I recognize your
Got
voice.
it. Thank you, Mr. Chairman, members of the committee. Tony Decklever with the Wyoming Nurses Association. Calling in from Atlanta, Georgia, where it's very hot and very humid down here. But I just wanted to share that the nurses are very much in support of all kinds of different options that people are bringing up even today in regards to maternal health and the maternal deserts. Some of the things that we have talked about is what Jen Davis also talked about with training some of our training some of our emergency room folks where they do not have OB services, because we know that folks end up in an emergency room if they have a complication or are in labor. And so to provide them with some training so they're more comfortable with those kinds of circumstances, we are huge supportive. The other thing that we are also, we encourage recruitment of our OBGYNs, but we should also be looking at our certified nurse midwives. And even though we don't have a certified nurse midwifery program in the state of Wyoming, to make our state welcome to some of the CNMs that might come from other states, we feel like that would be important and a priority also. So with those, I would stand for any questions.
Thank you very much. Hope you're enjoying Atlanta.
Thank you.
All right. I think, anyone else online for maternal health? Anyone else in the room? Go.
Wendy Volk would like to testify.
Wendy Volk, all right. Ms. Volk, if you can hear me?
Mr. Chairman,
Please proceed.
Mr. Chairman and members of the Joint Committee, this is Wendy Volk. Can you hear me okay?
Yes, ma'am, please proceed. Yes, please proceed.
Yes, thank you. I just want to thank you for bringing this matter before your committee. I do urge our Wyoming policymakers, healthcare providers, and communities to come together like we are today, to work together to ensure that our families and moms receive the quality of care. I do believe that pregnancy is a private matter, should not be a political matter. There's too many variables that are very personal. I just want to tell you, it was 18 years ago last week that I was pregnant in Cheyenne, and thankfully I was able to receive the medical care that not only saved my life, but also our daughter, who was born at 28 weeks. Had I been in a desert community, let's say like Rollins or perhaps Evanston, I don't know if I would be able to tell you the statement that I'm going to give to you is that I was able to be hospitalized. I was able to receive a level 2 pregnancy care for myself, and then I developed severe complications from preeclampsia. My placenta abrupted. There was no time for me to be evacuated by air to Denver. The cost of that was, at that time, 18 years ago, was a $27,000 air ambulance evacuation. That's now close to $100,000. And our daughter was air evacuated and to Denver, and she was at Presbyterian St. Luke's and also Children's Hospital for her care. She was there 7 weeks, and then in Colorado, they wanted to bring her back to Cheyenne, and I had to negotiate with Blue Cross Blue Shield so that we could get her life flighted back to Cheyenne so she could spend her remaining hospitalization time before coming home at 3 pounds. So she was born at 1 pound, 11 ounces at 28 weeks. She came home on oxygen at 3 pounds. But we had top of the line medical care. I'm so proud of Cheyenne. I appreciate Dr. Renee Hinkle saving my life. I also appreciate the other OBGYNs that have spoken before you today. I'm very proud of what we have in Cheyenne. I wish every community in Wyoming had what we had in Cheyenne, but we don't. And just know that everything regarding the ambulance care service and also air ambulance, the women in Rollins have to be life flighted out. Or if you don't have insurance and can't afford to pay for that out of pocket, which most people don't, you would need to, take matters into driving on Interstate 80 to seek medical care to Casper, Cheyenne, Laramie, or to Colorado. And that is not always safe. And if you were a single mom, I don't know how you would do that. We don't have the resources in being the least populated state. I really appreciate this time and energy, but we need to incent doctors to stay in Wyoming and come to Wyoming. As a real estate professional, I'm spending more time with doctors wanting to leave Wyoming and families leaving Wyoming and trying to convince, friends and family to stay here. So this is a really top of the mind awareness that we need to give much more attention than just this committee. And I appreciate your time.
Thank you, Ms. Volk. We appreciate you. All right, I think that's the last of our maternal care public testimony. So now we're going to proceed to EMS, and we'll start with our good commissioner from Fremont County. Please introduce yourself and proceed.
There it is. Thank you, Mr. Chairman and committee. My name is Mike Jones. I'm a county commissioner from Fremont County. Looking back over the conversations of EMS, and a couple of weeks ago, Senator Barlow left a challenge to some folks of us that were at a convention with the WHAM group, saying, "Bring solutions, please bring solutions." And I think earnestly, we try to come up with solutions, and I think that we've heard some today. I think the primer that came out of the Department of Health was very good. We've seen some solutions out of the EMS task force that came out of the governor's group a couple of years ago, the upper payment limit program that started here. We still have some challenges there. That came out of that. The EMS bill. That is it's a good bill. It gives us an additional set of tools for us to operate on. We've struggled with that in Fremont County because it is and in this tax environment or anti-tax environment, we're struggling with, it's a property tax. And it's not the most equitable tax that we have. And we've got the reservation sitting in the middle of us that doesn't pay a lot of property tax. I think we have a way around that, and I think we're going to try and take a shot at that. Doesn't mean we're going to get it, but we have gotten some bills. I mean, we have gotten some tools over the years. And as I was thinking about that question and that challenge to us, I am wondering if this committee could take on the question of what is the role of the state in EMS? And it seems like that's what we're doing, is dancing around that question a little bit of what is the role, if any? And if it's not, then good, let's all go home. But if there is something, because I think we should remember that there's not one size that fits all. I think in Mr. Laycock's survey, I think there's a lot of hidden gems in there, but there's also some hidden rocks in there as well, because Laramie is not Lander and Riverton is not Cheyenne. So I think that we need to keep that in mind. I would love to see that question being thrown out either in this committee or elsewhere and say, is there a role to be had? And if there is a role to be had, then are there other tools that we could be looking at? Certainly with the MRG subsidy program that the state kicks in for air service, and then the local communities kick in as well. It seems like there are models out there that could take into account, and I'd love to see, and I hate to ever recommend that we would do another subcommittee to study that, but to really come up and wrestle with more of those solutions. Like I said, I think we've heard some good ones today. The one last thing I wanted to just touch on is we've bumped up against this in the past, is that I think EMS education, we have to take a look at that in the state and say, where does that belong? Does it belong in one or two centers that people have to travel to? Or do each of the community colleges need to have some sort of skin in the game there? I know our local provider has taken on that role themselves and put on courses out at the tribes for us. I think we've had struggles with CWSC because it's not authorized by the Community College Commission. And it's like, okay, why did we do, how long of a dance do we have to do around that? I don't know. I don't understand all the complexities of that. But anyway, I just wanted to answer that challenge a little bit, but also put one back and maybe wrestle with the question, is there a role? And if there is, what is it? And maybe we should move forward with that. Thank you. I'll stand for questions.
Thank you. Any question for Commissioner Jones? Questions for Commissioner Jones? Thank you very much, Commissioner. Mr. Sweeney, please proceed. The mic is closest to you, but go ahead.
Thank you, Mr. Chairman. So I'm just facilitating. Leah Juarez, Mayor Juarez, is online. And Summer, I will turn this over to her. It's about the packet that just got handed out from the City of Mills, and Summer will take it from there. Thank you, Mr. Chairman.
Thank you. Mr. Sweeney, go ahead and introduce yourself.
Thank you, Chairman and Committee. My name is Summer Moline, and thank you for the opportunity to speak today. Mayor Juarez is traveling, but hopefully she's online. Hopefully we can pull her up and she can answer questions for you. I'm here as her assistant to present to you the financial EMS packet on her behalf. So can we pull her up online? Thank you.
So go ahead. You keep going, and we'll let her weigh in if she wants to, or do you want her to actually present? Why don't you go ahead and maybe
Okay,
she takes some questions
Perfect.
or
So
summarize.
that's fine. So I won't have the intricate details, but she will to answer your questions. But Mayor Juarez has gone deep into the financial aspects of the EMS service to better understand the mechanisms of its success and its failures. And along the way, we have discovered many additional issues that hinder the vulnerability of funding the EMS services. So with this packet, we hope to provide some deeper context for you into the complexities of staffing, funding, and billing. So she'll be able to, if she's right there, there she is.
Hello, Mayor Juarez. Great to see you again this week. Saw you last week. Can you hear us well enough to provide testimony?
Yes, I can. Hopefully you all can hear me, committee, chairman and committee. If not, just
Please
raise your
proceed.
hand. I'm watching the video. I appreciate
Please
your
proceed.
time and recognition. So Summer did talk a little bit about the pamphlet there. We've spent a lot of time trying to figure out the financial aspects of the EMS and how to sustain it. For lack of a better term, we've fixed the Titanic-sized hole in our EMS revenue source. However, it's floating, but it's not, fully sustainable at this point in time. So we're trending upward with what we're doing. In that packet talks about some of the things that we've come across while trying to solve some of those problems. I do think that finding a billing company would be highly beneficial, but the key part of that is a billing company that is highly motivated. And to be fair, through the lens of that, when they're looking at $1,600 for billing, it's just not worth their time. So they're not going to pursue it as actively as like a large hospital bill. After that, you want to add in the layer of the collection agency because, about 30% of our bills go to collections that are unpaid. And in-house, we've incentivized the ambulance transfers so our crew can pick up extra shifts. And that's where the true revenue lies for us, is in those ambulance transfers. But the big thing that I think that this committee can do and look into is Medicare payments. So that reimbursement from the state is $573 of our $1,600 ambulance run. So this year alone, we've billed $117,000 to Medicare, and we might get $77,000 if we're lucky. And then the other issue being what's called contractual allowances. And that has to do with the insurance companies themselves. And so we discovered that a lot of them have these binding contracts that held, for instance, the city of Mills was bound to this contract in 2013, which means that we can only get reimbursed for X amount of dollars, and we're not allowed to balance bill the patient. So in this packet is provided to you guys kind of some more of these details as to when we've gone through this journey and the issues we found and tried to overcome, so that we can not only share it with you guys, but share it with other communities as well. And my ask, and before I take too much of your guys' time, is that Mills be involved in this conversation moving forward, because we really do have some key takeaways from the time that we've spent on this. And with that, I really appreciate the community's time, Chairman. I would be available to stand for questions if you have any.
Thank you, Madam Mayor. Any questions for the mayor? Madam Mayor, just to remind me, I know we talked about this last week, you have a town-based EMS, is that right? I mean, it's through your city government?
You're correct. Correct. It's a fire/EMS type service, and it's all ran through our city, and we contracted a private biller. So we're very fortunate that this individual is charging us very little to help fix our system, which is rare in and of itself. But we found with this that this individual has substantially more buy-in to the community, because she's able to pursue things at a higher return rate than our previous medical biller. In 2023, our previous medical biller was left on the table $445,000 due to aging billings. So there's a 9-day difference between these companies that are bigger and somebody homegrown.
Thank you. Appreciate it. Further questions for the mayor? Further questions? All right. Thank you very much. Safe travels. Thank you for not driving.
Thank you.
Talking on the phone.
Appreciate it.
Hey, did you want to finish anything out, Ms. Summer? All right, thank you very much. Anyone else is going to testify, come on up on this topic. Go ahead, Ms. Davis.
Thank you, Chairman Barlow. Again, Jen Davis from the Wyoming Primary Care Association. Some of you on this committee know my passion for this topic. When I was in the governor's office, we had the EMS subcommittee that did a lot of work on information that's been in front of you with the Department of Health. In my opinion, EMS is the backbone of our healthcare system. If EMS doesn't work, the rest of the healthcare system doesn't work. Because how does somebody access care if they can't get to care? And that is the case for EMS for many of our residents. It's the case for many of our tourists that come through Wyoming. Tourism is one of our biggest industries in Wyoming, and we have a lot of people who come through here on our roads, and even though only 1% to 2% are due to crashes, they also are getting lost in our wilderness. They are having heart attacks in our hotels. So again, we have people accessing this system that are both our residents and our visitors coming here. And so this is really, in my opinion, an infrastructure issue. As we think of infrastructure, Commissioner Jones made a good point of, is there a state responsibility in this? And as we think about an infrastructure, this not only is about healthcare, but a few months ago, we had a tunnel collapse in Rock Springs. I don't know if any of you remember that, but that needed an emergency response. We had a tornado that hit one of our mines not long ago. That required an emergency response. So it's not just going to people's homes. It is responding to any emergency that we have in this state, which in my opinion makes it an infrastructure discussion, which does have a state role to play. If we want response for all of those things, then we have to make a plan to develop that infrastructure and make sure that it's sustainable. I hear a lot of things over and over again that, well, we just need more volunteers. The days of volunteers in our systems are gone. Let's just be honest, people are needing to work multiple jobs. It's not like it was 20, 30 years ago where people were able to volunteer. It is different. Our generations now are different, how they value volunteerism and do it in other ways. So we have to think about an infrastructure that we invest in, that is paid for. I know not everyone agrees with this because it's very expensive to pay for a ready service. Look at hospitals. It's very expensive, but you have to have the people there and ready to respond if we expect to save a life. And I don't know about you, but I think any life we save is invaluable. So I don't know how you put a price tag on it. But what we need to do is really think about how we do this collectively. And that was really the benefit of the task force, is we had all the players at the table, insurance, industry, state agency, to come up with solutions, because it's not easy. This is a very complicated system. But again, we have been talking about this for many, many years, really targeted for the last 4 years. And quite honestly, we're in the same spot that we were. We've done a few little things about eating at the edges, but if we really want a sustainable infrastructure in Wyoming to save lives, whether that be in our mines, a tunnel collapsing, a heart attack in your house, we have to make a concerted effort to do something with this. So what I'm asking of this committee is really, really take this to heart, and let's find something to do this session. Again, we've been talking about it. There are lots of things that we can do. Department of Health puts forward some ideas today. You heard that Medicaid is already paying for non-transport EMS, which is huge. Nobody else is. So can we work with our insurance payers in the state for them to also pay for it? Medicaid is also paying for community paramedicine. It is pivotal prevention. Medicaid is paying for it. Guess what? They're the only ones. Can we get our private insurers? We can't control Medicare. Director Johansson and I have gone over and over and over with Medicare, and we haven't made a lot of progress. So we really need to lean into, if this is important in the state of Wyoming, what can we do in the state of Wyoming? Because we have no control there, but we certainly can still save people's lives. So we can look at things like requiring payment for those. We can also look at legislation that's happened in other states where EMS is allowed to transport to step-down care. Instead of going to the most expensive of the ER, can they transport to a clinic? Maybe somebody, Phil, has a minor injury and just needs to be checked out further by their physician. Can they transport there? So there are lots of things out there that states have done that are very successful. So what I ask is, let's do something for our people that live here and that visit here. And with that, I'll stand for any questions.
Thank you very much. Any questions? Any questions? Seeing none, thank you very much. Any comment online besides Mayor Juarez? No? All right, perfect. So committee, we've only gained 17 minutes since but we're gaining, I'm just telling you, we are gaining. But I think there's been some suggestions come from the audience today. I don't think we try to go through those right now, Madam Chairman, at this point in the day. I think folks can think on it, if that's okay, if there's no objection, think on it this evening. If there's bill ideas or suggestions or things we want more information on, let's take that up tomorrow after we get through some of the rest of our topics. So you've got some time to think on it. Absent objection, we'll proceed that way. All right. Our next topic is 1 hour and 24 minutes behind schedule. And I'd like to welcome the Coroners Association, Department of Health, whoever's going to testify on our toxicology death certificates topic to come on up, and we'll get started. Great to have you here today. Please introduce yourselves for the record, who you're representing, and then proceed with your testimony. Thank you.
Good afternoon. What a long day. My name is Erin Ivey. I'm the coroner for Fremont County, Wyoming. And I'm also, I'm sorry, a little ill. I'm also the president of the Wyoming Coroners Association.
Thank you. Ms. Ivey?
Yes, I-V-I-E.
Thank you. Go ahead, sir. Introduce yourself.
And I'm Jim Whips. I'm the Natrona County Coroner and part of the executive board for the Coroners Association.
Perfect. We've got almost 10% of the association here. So go ahead.
Well, I'm really not too sure what this group is wanting from the coroners, although I did read that the priority was toxicology and death certificates and the relationship of mental health and the death certificate itself. So I'm not too sure what exactly we're looking for and how can coroners help.
So I guess one of the things, and I just actually had a family member that was killed in an accident not long ago, so I've interacted with a coroner, and one of the questions that came up was the accident, it was a vehicle accident, and there was multiple vehicles involved. You know, what is the process for determining whether they're, you know, drugs or alcohol or, you know, any altering substances were used, and how is that? I mean, obviously it's going to be, if it's found, it goes into maybe some criminal proceedings, but what is your standard process for that? And then maybe some of the committee members, that'll prompt some of the committee members to say, well, this is what I'm interested in. And maybe it has to do with mental health things, but just give us an overview of anything you interact with that might actually cause for some testing and toxicology. I'm just using the accident as a starter. Go ahead, please. Mr. Whips?
So for every case that is a coroner's case where the coroner takes jurisdiction, which would be your accident, your homicide, your suicides, those kind of things, it is mandatory by rule that toxicology be drawn by the coroner's office. It is only tested when we determine that there's a need. The question that needs to be answered is whether or not that toxicology was a contributing factor to the death. So like your motor vehicle accidents where they're the driver, that's an obvious. And then we take and send that toxicology, usually off to an outside lab, where we get a quantitative result on the drugs, medications that are in the system. And then with that being quantitative, we can then determine how that affected that particular individual as far as the toxicity levels. And that will become part of, if it was a contributing factor, part of that death certificate process, so on and so forth.
Okay, thank you very much. Go ahead, Ms. Ivy.
Just briefly, I'm just going to reiterate, because I had a little thing written up, that the elected coroners are required by law to obtain toxicology samples on every decedent that meets the requirement for a coroner's case. So that would be like Coroner Whip said, is any accident, homicide, suicide, undetermined or unattended natural death. Relevant toxicology is reported on the death certificate and put on the public docket as required by federal and state law. Therapeutic levels prescribed medication may not be listed if they're being taken as prescribed. So if they're not being overused or underused, it may not be listed on the death certificate. And if somebody is not using, what we may say is medical noncompliance. So it is on the certificate that they're not taking the medication that they've been prescribed, but if it's therapeutic use, it would not be relevant necessarily because it's been prescribed and they're not overusing. Unless, of course, that medication is overused and it is relevant to the cause and manner. So then we would put what the medication is specifically that is related. So if it's alcohol, we'll put ethanol. If it's rubbing alcohol, we'll put isopropanol. So it'll tell you what different types of toxins are in the system at the time of death. Some of them are difficult to determine after death because the levels change. Post-mortem toxicology is not the same as antemortem or before death toxicology, which is why we use a forensic lab that's specialized in post-mortem toxicology. We do a thorough review of medical records, and though that's completed, and noncompliance then, of course, is commonly listed. So if it's not relevant to the cause and manner of death, it will not be placed on the death certificate.
Okay, thank you very much. Any questions from the committee? Questions? Representative Guggenmoss.
Thank you, Mr. Chairman. My interest in this topic was to try to gain some sort of correlation, see if there's any connection, for instance, with the issue that we had in our state with the murder-suicide, where there is an instance where people just act completely out of norm and they do bad things like that. Polypharmaceutical stuff.
Polysubstance abuse?
Yeah, is, from what I've heard, is not really tested on how these different drugs interact with each other. And these doctors are prescribing all these different kinds of psychotropic drugs, antidepressants, so on and so forth. And my question is are we having an issue that is causing people to do things completely out of the norm and kill other people, commit suicide? Is there any way we can track that?
Go ahead, please proceed.
I'm sorry, to answer that question, not necessarily on the death certificate itself. There are tracking systems already in place, like the Wyoming Violent Death Reporting System, and they can access all of the coroner's report, toxicology reports, autopsy reports from the coroner's office by request, and they compile that data on I believe it's a biannual basis, and put that out. Could be annually. I'm sorry, I'm not positive. But they do ask for that information from coroner's offices. There's also, I'm going to butcher what it stands for, SUITRS, which is the sudden unanticipated or unexpected overdose deaths reporting system. So any overdose death is reported to SUITRS, or they'll request the coroner's report docket, toxicology, whether it's relevant or irrelevant, the entire toxicology panel that we have. So caffeine, nicotine, those things will be included. But as it pertains to the case you were mentioning, neither one of the medications that she was on ended her life. And so for our purposes is, what is the cause of death? The cause of death is a gunshot wound. What's the manner of death? Suicide. This happened, she did this to herself. What's the manner for the other people? Homicide. One person's actions resulted in the death of another. It's very cut and dry. It's, we're not The ruling of homicide does not imply guilt or innocence. It's a neutral term for the coroners to use, just saying that one person ended the life of another. And then suicide is one person ended ended their own life. So taking into account their medical history, we do look at, say, do they have previous suicidal ideations or attempts? And that might get listed on a death certificate of prior suicide attempts if we rule something as a suicide. Did that answer your question at all? Or did I dance around it a little bit?
Well, so, and I'm just gonna, could you, where is this Wyoming violent death repository? Who actually manages that?
The Department of Health.
The Department of Health does? Okay, and then you had a second one, Suitors, which,
Suitors.
I don't know if we got.
Department of
that's
Health.
Department of Health, okay, thank you. They're gonna get up here pretty quick. All right,
So-
further questions for these folks? All right, sorry, Representative Ottman.
Thank you, Mr. Chairman. Ms. Ivy, how are you?
I'm well, thank you, ma'am.
Good, good. Just a couple things, because on the DOI task force and then with the case that Representative Guggenmoss was talking about, one of the things that we're looking at, and I see that you guys have a specific scope of practice, but if we're looking at, if we want to know if certain, for data or whatever, if certain drugs are causing certain reactions in people, like if they're getting phobias or if they're doing all these things, if we don't have accurate accounts of people that were doing these things, maybe when they committed a violent crime or maybe when they harmed themselves, what I'm wanting to know is how is it that we can, because there's privacy too, how can we get some data on the harmful effects of some of these things? And so that was one question. And then I wondered is there a limit to the testing that you do? Like you say, okay, they were killed, I mean, they were in an accident, so how many tests are done? And is there a time limit on the body? You had said like pre-accident or pre-mortem compared to post-mortem or however it is, what that time limit is, and what kinds of things are red flags for you to check? And so just kind of a synopsis of that, because we're really wanting to get some data. There's some things with certain drugs that people are doing quite often, and we're trying to see what effect those have on people, and if it causes this irrational behavior.
Go ahead. I don't know if there was a question in that, but go ahead.
Mr. Chairman and Madam Representative, for the suspect committing a homicide, we have no jurisdiction over that suspect. I have no idea what they've taken. It's just the decedent that I would know any information on. Okay. So the person who acts irrationally and causes the end of life for somebody else, if they're not also deceased, I have no idea. That would be left to the criminal justice system outside of the coroner's office. As it pertains to how people are acting or whether or not this changed their behavior, there has to be somebody else present at the scene when I get there, because it is impossible for me to extrapolate that information from a decedent, how they were acting, or if they were feeling ill because these two drugs interacted, or just interacted in their system differently. There's no way for me to know that without having somebody else present to say, was your loved one ill? Were they, acting differently? Did their medication change recently and they've had a adverse reaction to that? Outside of that secondhand information, and oftentimes people don't talk about whether or not they're having adverse reactions, so we may never know how those correlated together. So I don't know if that answered the question. So for Fremont County, we're a little bit different than some other counties where we test all toxicology. we send it off for a basic comprehensive or a basic panel, which includes the most common drugs of abuse. In that, if they find one that's off that testing spectrum, then we can add the expanded panel. If we find something that's off the expanded, we can go to the expert panel. And then at the very end, we can go to the total comprehensive panel, which makes it sound like we test for everything and anything under the sun. That's not true. That's impossible to do. But we're looking, because we can't ask, what have you been taking? What are you taking now? We have to just do kind of a basic screen. Our basic screen, I believe, covers 200 common drugs of abuse or thereabouts. 200 common drugs of abuse, our basic toxicology screen. So that includes barbiturates, amphetamines, stimulants, alcohol, different types of alcohol, like I said, isopropanol versus ethanol versus methanol. But some things do change after death. So somebody who passes with no isopropanol in their system may have it after death because our body breaks down and creates it. So they are not necessarily drinking, rubbing alcohol. It's just that they've been deceased long enough that their body has started to produce it. Another one is glucose. Our body is made up of sugar. So in order to know if somebody's a diabetic or not, we can't do a blood finger stick because glucose starts, it will jump really high after death because it's eating everything in its path, and then it drops drastically. It dies off very quickly. So we have to do a vitreous glucose, which is the fluid of the eye. And that will give us a more accurate reading. But even that is still plus or minus 50 either direction.
Follow up, please.
Please. Representative Ottman, follow up.
Thank you. And I guess what I'm just picking your brain is basically what it is. So basically what I'm wanting to know then probably would be from the state lab. So when you, when there is a report done and you give those fluids or that function or whatever it is, and that report is out, if someone down the road wanted to look at that or whatever, is it still available, or what do we, yeah, that's where I'm going with this.
Please, go ahead.
Mr. Chairman, the full toxicology report is not a public record under Wyoming statute. The relevant toxicology is included on the docket that is released to the public. So if somebody is taking hormone replacement therapy, that may not be relevant to their car crash. So it's not going to be on the docket, any relevant. So their alcohol level would be listed, or their methamphetamine level, or something that would impair your driving. But your ibuprofen is not going to be listed as a relevant toxicology. And it's the relevant toxicology that is public information.
Thank you very much. Yes. Madam Co-Chairman.
Thank you, Mr. Co-Chairman. Ma'am, Representative Guggemos mentioned a tragic situation that occurred in Bighorn County. And obviously the impact of that affects the community and perhaps maybe even public trust in the mental health system when it comes to psychiatric drugs and prescribing. Do you see the need for the state to reliably track the role of psychiatric drug use when it comes to violent acts that occur throughout our state?
Please proceed.
So, Mr. Chair, and I can only speak for my jurisdiction, the common drug of abuse is alcohol. And so we do track that. Methamphetamine would be next. I have not seen a huge uptick, at least in my jurisdiction, of prescribed antipsychotic medication or mental health care medication that's prevalent in any of our deaths. And Jim,
go ahead, if you'd like to.
I can tell you that's probably the same everywhere. Now, we will gather data on all these drugs through that toxicology, but where we play is whether or not that was relevant to the death. And a lot of times, you know, especially when you're talking about violent acts and those kind of things, it's really not for us to decide whether or not any particular pharmaceutical was affecting their mental well-being and causing the violence. I mean, you just don't know that. I mean, we can assume, but then we're asking for an opinion, and we like to keep our stuff to fact. We will list it on that death certificate, illicit or prescription, and the type of drug that it was when we feel that it was relevant. And that's usually when it comes back extremely high with your illicit drugs that would be overdose level, or even in a violent act if, and this really only applies when you have something like a murder-suicide, where the offender is also dead, and you can see that they have a huge amount of THC, methamphetamine, even prescription drugs that are way outside the therapeutic level, those kind of things. Now that will get listed as a possible contributing factor to that cause of death.
Thank you. Maybe let's bring up Department of Health and let's understand a little bit how these death certificates go and how the vital statistics may interact with this. That'd be helpful, maybe. You're kind of coming from two directions. But you don't have to go away because there's a question that comes out of this, but go ahead, Director, please.
Thank you, Mr. Chairman. Members of the committee, again, Stephen Johansson with the Department of Health. Appreciate the testimony from our coroners. I couldn't do a better job describing the process. In that death certificate process, we really become the custodian of that certificate. So we govern the process based on state law. We irritate them with regulation and policy on how they should fill out the forms and what, whether it's primary, secondary, tertiary cause of death or other factors that go into that, physician or medical provider consultation, a whole bunch of rules, and then we become the custodian of that. To the point that was very well articulated earlier, we can certainly analyze data as the coroners can as well of what factors are prevalent, what correlations might be relevant in any sort of death that results in a coroner's case. I would just caution that with data like those, drawing lines of causation is very difficult. When our numbers in Wyoming, when we talk about homicides, suicides are so low, and you try to draw connections or correlations between chemicals that might have been present, et cetera. I sympathize and fully understand the frustration with that question. We have it too. We want to know the causes of these things, the prevalence rates of how certain areas of the mental health system or pharmaceuticals or any sort of toxic chemical or substance could be causing certain phenomena. But again, our numbers are just so low in Wyoming that those studies are difficult. Not impossible, but difficult. And so we often look to national studies that have a little bit higher statistical power, a little bit more volume there. And we're happy to do some research and maybe just provide some recommendations on where to look to the committee. But in terms of the questions that came up in some of the other data sources outside of the vital statistics services or vital records system that we maintain in the Department of Health, a few systems were mentioned. Our violent death reporting system, we do have reports we can share with the committee out of that. Again, same kind of caution on causal links. Again, not to say that the data isn't relevant and interesting and correlations might be there, but again, causation is difficult with low volume. But this discussion is really helpful to help us maybe discern some areas the committee might be interested in. More than happy to be of assistance with those data sources that we do have. For example, I think there was a report from 2022 that showed out of 350 or so suicides that were analyzed, there were 137 that had some sort of toxicity or chemical present, and that can be broken down. Correlation, yes. How much we can inform the committee in terms of policy action on what the causes might be. Not to overly irritate you, but I know it's frustrating, but it would just urge caution on that. But again, happy to research some of those connections that might be, or studies that might be out there nationally or internationally on some of these topics, because I know it's of great concern to the committee. So with that extremely frustrating testimony, Mr. Chairman, happy to answer any questions that the committee might have on this topic.
Any questions? Any questions for the Director? Representative Wasserberger?
Thank you, Chairman. Is there any correlation to HIPAA applying to the studies after somebody has deceased, or does HIPAA no longer apply?
Go ahead, please, Director. Thank you.
Mr. Chairman, Representative Wasserberger, the answer is it depends. In most of the Department of Health, we're a fully HIPAA-covered entity, so we take protected health information and privacy very seriously. Vital statistics, given that it's governed by state law separately, is not part of the HIPAA umbrella in the department. There's still privacy regulations there, of course, and we respect those. But as was mentioned before in testimony, there are public records associated with certificates that we have in Wyoming and the data that's available there. When we get into, especially in Wyoming, small populations, small counties, things happen, smaller populations. Outside of vital records, we would need to be very cautious with both HIPAA regulations and privacy restrictions in general, just so we're not inadvertently identifying inappropriately members of your communities or their families, even historically, who might have experienced some of these traumatic events. That's not to shut down the analysis or the debate or say we can't be of assistance, but just another word of caution, we would want to take that very seriously. It's something that, quite frankly, we beat into our staff at the Department of Health to make sure that the data that we have, the data that we share is fully analyzed for that type of protection.
Thank you. Senator Scott.
Mr. Chairman, my question is, do you know, does the Department of Workforce Services still maintain a database and analysis of workplace deaths? Because they were doing it, I think they were sometimes looking at these coroner reports doing it. Mostly showed that it was motor vehicle accidents. Do they still do that, or they no longer maintain that?
You're welcome to answer, but Workforce Services will be here tomorrow, and we'll remind the good senator of this question.
Mr. Chairman, Senator Scott, I believe so, but your best bet is to ask Workforce Services.
I think that's through the OSHA program, and I'm confident they still do, but we'll check in with them tomorrow. All right, further questions? Yes, I'm sorry, Senator Steinmetz.
Thank you, Mr. Chairman. I just heard something that kind of perked my interest, and that is we keep hearing we're leading the nation in suicide. We put in suicide hotlines. We're doing all of these things, but you're telling us our numbers are so low we can't find any correlation, find any evidence. Could you just clear that up for me, because that's a little confusing to me.
Go ahead, please.
Mr. Chairman, Senator Steinmetz, it's a good question. Just to clarify, it's not to say we can't draw any conclusions or do the analysis, just to indicate and urge some caution that with low numbers, causal links are hard to draw unless you have multiple years or even decades of data, so that you kind of adjust through that statistical noise. For example, a county that has 2 more or 3 more suicides in 1 year compared to the last might show a 250% increase in, so you wouldn't want to react to that in policy when it might go down 300% or go down, 90% the next year. That's the difficulty I was alluding to. But as I mentioned this morning, we have seen 2 things. Over the past couple of years, we've worked to develop better statistical methodologies with our low volume to incorporate some more advanced modeling because of our low observations that we have in Wyoming, and really model counterfactuals running, hundreds or thousands of simulations with the same data observations that we have. And that's what I was alluding to this morning, that just in the last 2 years, we have seen the first indications of a flattening or even a dropping of our suicide rate in Wyoming, which is really promising, potentially connected to some of the efforts like 988 or more prevention or awareness that's out there. So that's promising, but again, early indications of some progress there. But we're happy to share the reports that both on 988 and our suicide trends that we really have produced recently that I think give a better analysis than in previous years of just showing tables and figures and numbers year to year, which is really hard to draw, any sort of conclusion from. This shows it over a greater time span and uses more advanced modeling to show kind of how we look both statewide and county by county.
Thank you, Co-Chairman.
Thank you, Mr. Chairman. Director, so the department alerts the public when there's a measles outbreak in a nearby state. and they prepare the public what to look for, and obviously they probably have a plan, and then you have an epidemiology section of your department, et cetera. So when it comes to, we're talking a little bit about suicide and psychiatric medication, is there anything in place within public health that creates a threshold for alerting the public? So say, for example, we have suicide by cops that start occurring, or a suicide contagion or something like that. And the common denominator is a new SSRI. Is there anything or any mechanism in place within the Department of Health that there's that threshold that you would alert the public?
Please,
based on toxicology and some of the things we're talking about?
Please, Director.
Mr. Chairman, Madam Co-Chair, it's a good question. I think in terms of specific thresholds, numbers of incidents, et cetera, no, there's nothing in that triggers, an alert from the Department of Health. However, we do produce a lot of information and reports, both in public health, our prevention units, our epidemiology units, press releases, et cetera. The violent death reporting system reports that we put out are available. Two things: how good of a job we do promoting that, or how interested the public or decision makers are in that information can vary. And so we'll take ownership of that when we maybe not be doing a good enough job putting out what could be recent or concerning trends in those areas. But we do have those processes both with infectious disease, communicable disease, as you mentioned, as well as reports, as I mentioned, that are relatively new in the last 5 to 10 years that we have these types of systems using death records to look at violent deaths. That's a newer function in the Department of Health, relatively speaking. We could certainly do a better job promoting those data and those reports, but there's no specific threshold where we have looked at if we reach this number in one of those incidents that it triggers a news release or a conference or a specific report in that regard. So certainly something we're happy to look into.
Go ahead, Mr. Guggenmoss, Representative Guggenmoss.
Are there any studies that have to deal with the polypharmaceutical use and how drugs react to each other when combined? You turn on the TV and all you see during the advertisements is all these different drugs, antidepressants or whatever, that may cause depression or may cause suicidal thoughts or may cause violent actions. So is there any kind of scientific study on what the correlate, or if there's any reaction to taking polypharmaceuticals?
Go ahead, Director.
Mr. Chairman, Representative Guggenmoss, I'm sure there are. I'd be, over my skis trying to point you in the best direction today. Like I said, we're happy to do some research and use our expertise to point out where we see good peer-reviewed higher volume studies in those. I just don't know off the top of my head where I would point you. I do think it's relevant to mention that polypharmacy, as long as I've been here, but especially in the last 5 years, in some of our health facility settings, like at the state hospital, our nursing homes that we run, and in the industry in general, has become much more of a focal point from federal regulators, licensing entities, Joint Commission, et cetera, to look at that as an issue that can cause behaviors, but in a very specific, setting like a psychiatric hospital or a nursing home that has a locked dementia unit, we can actually be tagged on things like overuse of polypharmacy, and the industry can as well. So folks, my folks in the department, and certainly members of the public in the industry would be able to speak to that as well. But I wouldn't know today where to point you in terms of a high quality study that is attempting to show any of those causal links that you're referencing. And it's not to say that they're not out there. I'm just not educated enough or aware of them to point them out today.
Thank you. Questions for our panel? Thank you very much. Anyone want to give public comment on this? Public comment? Public comment, going once, going twice. I think it would be helpful, Department of Health, maybe that 2022 work that I think has already been produced, maybe forward that to the committee, just so we have an idea of what's already available out of your reporting. And then if we decide to follow up further on this topic, I say we maybe bring in the pharmacy board, someone that actually, and there's also adverse event reporting that's required for prescribers. Someone doesn't have to die to have an adverse reaction. It's the reality. And so even as a veterinarian, there is a reporting venue for me as a prescriber if I see what I consider an adverse reaction. So there is a FDA type portal to do that type of thing. So there might be something there of interest too. So, all right, anybody on Zoom for this topic? Thank you. Anyone else in the room on this topic? Seeing none. Any just general public comment for the good of the order? General public comment for the good of the order. So we are now 58 minutes from our time. So we've made up another 59, sorry, 59. We made up a little time. Thank you for your patience today. I hope the committee and the folks that attended found the morning informational, the afternoon. Yeah, we got some things to chew on overnight. Hopefully we'll have some ideas that come forward. There's no further business. Madam Chairman, do you have anything else? No. For the good of the order? So we are on recess until tomorrow morning at 8:30, same time, same place. Look forward to you. Have a safe evening. So for the committee, this room is secure tonight. If you don't want to take your packets or whatever.